Just a couple of seconds. All right, so let's begin recording. I will start right away. Great. All right, good afternoon, everyone. Thank you very much for joining us for another edition of our Keeping Pace seminar series. I'm Dr. Diallo Brown. I'm the co-chair of the Jamaica Association of Sports Medicine's Education Committee. With me, I have Mr. Fabian Miller, the co-chair, and Dr. John Rache, our previous chair of the Education Committee. We welcome our Keeping Pace seminars. Today's seminar is themed around interventions in sports medicine. So we have a few presentations lined up for you. All right, so I'll let Dr. Rache just start us off with a word of prayer. After that, I'll go into some housekeeping matters, and then we'll jump right into it. Thank you. Dr. Rache, go right ahead.
All right, you bow your heads and close your eyes if you so desire, and we're going to pray. Father, thank you for your many blessings. Thank you for the technology that has allowed us to be educated in one space so that we can learn about some of the interventions in the management of sports-related problems. Thank you for providing individuals willing to share their time and knowledge so that we can become better practitioners. Give the presenters clarity of thought and words. Help us to focus, to listen keenly, and to put aside any reservations we may have about asking questions, because it is through asking that we will receive the answers. Give us insight. Be always at our side. Keep us, your children, safe from harm and danger today and in the days, weeks, months, and years ahead. I ask these blessings in your precious name. Amen.
All right, thank you very much, Joe. All right, so as I mentioned, I'll just give out a few housekeeping matters. So as we do this seminar, we'll have a few presentations, as I mentioned. We allow about 10 minutes of Q&A after each speaker, so you can go right ahead and ask your questions. To ask questions, we just ask you to use the raise hand feature to first identify you with your question, or you can put questions in the chat. We'll be monitoring the chat, both the YouTube chat and also those on YouTube. Welcome to those on YouTube if you're there. We were looking at the YouTube chat as well as the Zoom chat for questions. In terms of certificates, so members, of course, will get certificates daily. If you're a member that's on the YouTube feed, please identify yourselves. Please just put a name in the chat so that you're there so we can actually see you. We know to send you your certificate. If you're a non-member of JSM and wish to receive a certificate, it's $1,000 for the continuation education certificate. And I'll send the payment information into the chat. It's important that you email both the Jamaica or Education Committee as well as JSM's main email, because sometimes we miss emails on one and we don't see it on the other one. So we're gonna ask you to email both accounts so that you can actually get your certificates. All right, I believe that is gonna be for housekeeping matters. So I want to turn things over to Mr. Fabian Miller, who's gonna be our moderator for today. Mr. Miller, take it away.
Thank you, Dr. Diallo. And we will move right into things. Let me introduce you to Dr. Kevin Gwyn Jones, former president of Jamaica Association of Sports Medicine. Dr. Jones is a consultant, orthopedic surgeon. He's also an associate lecturer in the Department of Surgery, Radiology, Anesthesiatics, and Intensive Care at the University of the West Indies, Mona campus. Dr. Jones' professional organizations that he's a part of are Jamaica Orthopedic Association, the Caribbean Association of Orthopedic Surgeons, international member of the American Association of Orthopedic Surgeons, Jamaica Association of Sports Medicine, past president, chairman of the Therapeutic Use Exemption Committee of the Jamaica Anti-Doping Commission, JADCO, Jamaica Track and Field Coach Association is also a member. Dr. Jones' research interest lies in injuries in high school athletes and their management, tibial plateau fractures, femoral shaft fractures, and associated blood loss. Dr. Jones is no stranger to the field, a man of many accolades, a man who serves his country. And I want you to give him a listening ear, as the information that he brings to us this afternoon is no doubt very valuable. Dr. Jones, take it away.
All right, thank you, Fabian, for that introduction. Most of people didn't mention I'm actually the substitute presenter. The individual who was asked to do the presentation is, well, unfortunately unable to attend due to national duties. So I was asked by Dr. Brown to present this topic, and I have put it together as best as I could given the time period. All right, can everybody see my screen? Share in my screen. It's up?
Yes, very clear.
Great. All right. So I've been asked to talk about medical interventions for sporting injuries, a very wide and diverse topic. And I mixed it with a bit of academia and practical stuff that we've actually done, and tried to go into different aspects of it. So it's a very large topic, so we'll try and get through as much information as possible. So my disclosure, as you already heard, I'm the chairman of the Therapeutic Use Exemption Committee for JADCO, so all drug and drug-related matters, I try to speak very deliberate and very clearly on it so that it's not taken out of context. I have used some surgical images. I should have given this disclosure before I put up the opening slide, which had an operation we were doing on a patient who had a nerve root and nerve entrapment. But there are surgical images in the presentation, so if you're a little bit squeamish and you have a stomach issue, I realize not everybody watching or viewing this presentation is medical, so if you have any issues, just turn your eyes away. And without that, I'll go into the presentation. Now, I've given the time frame and stuff, I managed to pull one main article on the subject matter and have used it and its references throughout this presentation. So it was done on adolescent athletes, so most of the references will be towards that, but a lot of it can be extrapolated to adult athletes. So participating in sports by adolescents generates many physiological, psychological, and social benefits. These include improved health, so overall state of health, reduced risk of chronic non-communicable diseases, self-esteem. It's been proven that persons involved in sporting activities, whether it be training, sporting games, etc., have higher self-esteem than those who don't. Social interactions, persons involved in sports and activities tend to develop social interactions better than those who are not, and that comes from, I guess, especially in team sports, your forced interaction and spending time with persons in a closed or confined environment for an extended period of time that forces you to deal with people from different backgrounds, educational based, etc. And there's a decreased risk of depression. So persons involved in sports, there's a decreased risk of depression. So these are all good reasons for individuals to take part in sports and play sports. Now, if you're going to play a sport, injury is almost inevitable. If you're going to, if you're alive, you're almost sure to get sick. In the study that I referred to, a study done out of the US in 2019, they found that 3.5 million adolescents under 15 received medical care for sporting injuries. Of these individuals, 2/3 required emergency room care. So 2/3 of the person of the 3.5 million, so that's the majority of them required presentation to emergency room for assessment and management. And then that similar study done in Africa over a 10-year period between 2003 and 2014 found that about 23 million African youths, and it's across all African continents. It was a multi-center retrospective study done. They had a protocol for it that was given to all different countries, and in filling out the protocol, they came up with about 23 million African youths on a yearly basis, and that's across all countries in the African continent. Now, the epidemiology, we'll run through these one by one. Each of them has a reference. I haven't referenced all of them, but the risk of sporting injury. So gender, and I put genotype because, as we know in this day and age, with the fluidity of gender, that you can have somebody who is playing female but is genetically male. So the risk in terms of gender and injury has more to do with your genotype than what your concept of what you are. So for XY individuals, the thought process for XY individuals, the injury rate in a lot of studies show that it is higher than XX individuals. That's in more older studies. In more recent studies, that has not been shown to be the case, because the thought process is that XYs take higher risk, more aggressive, and engage in sports that have a lot of physical contact and body physical trauma. Age defined injuries more prone in the younger adolescent age group and the older adolescent age group, so under 16 as opposed to over 16. Body mass index, some of it is intuitive. Body mass index, persons who are overweight and so on, increased risk for certain injuries, and usually at lower energies. A person with high body mass indices are usually at risk for low energy sporting injuries, so that injuries will take place without necessarily a lot of trauma. Competitive level, you think that professional athletes and amateur athletes, most recent studies show that the risk is about the same, I guess, but some show that it is higher in non-competitive athletes. And the reason being they're not well trained, most of them are weekend warriors, and so they're not particularly trained for the sport that they're playing, and so the injury rate tends to be highest amongst them. Hours of practice, as you might think, the longer you practice, the more time you spend out there putting wear and tear on the body, is a higher risk of injury. Single versus multiple sport, this is in terms of development. Most studies from professional sports, I've mentioned this at one time, we did a talk on specialization at an early age, but if you play a multiple sport growing up during development, studies from the National Basketball Association in the US and the National Baseball League in the US show that if you grow up playing multiple sports, you have a lower risk of injury than if you played a single sport throughout your whole childhood and adolescent life. Injury prevention training methods, so individuals who involve specific training methods to reduce the risk of injury. So like if you play a lunging sport, a racket sport like squash, badminton, tennis, where you lunge a lot, you're at risk of rolling your ankles. And as a result of that, we usually recommend persons do sports that they do ankle strengthening exercise throughout their training and throughout their careers. Mention warm-up, so as intuitive, there are persons who warm up properly for their event, lower risk of injury. Training facilities and equipment, first, if you have a playing surface that's uneven, full of holes and stuff like that thing, is likelihood that somebody's going to step in a hole on an even surface and twist an ankle and either break it or end up with some kind of a sprain. Training load, direct correlation between increased training load that has to do both in terms of volume and intensity and in terms of risk of injury. Techniques, for a person that employ the proper techniques, when they employ, when they do the particular sport, that's why, you know, nowadays, back in the days, it was trained to run fast. Now there are a lot of sprinting drills, you know, specific in terms of high knees, butt kicks, stuff like that. So sprinting drills to ensure that your body or parts of your body are going through the proper motions while you are doing it. And the same thing goes in your field events, etc. Nutrition, this hasn't been shown to be directly correlated with increased injury rate. I mean, although there's not much studies that have been done on that. We know hydration is critical for injury and injury prevention and the whole idea of being adequately hydrated. But in terms of nutrition, in terms of caloric intake and nutrient makeup, they don't really have any good studies or complete studies to show a direct correlation between nutrition and thing there. And external psychological stresses shows that persons who have increased pressure from outside, i.e. parents, well-wishers, do-gooders, old past students and other wagonist types who are there pressuring and athletes to do well, those individuals have an increased risk of injury. Now, the types of injuries are broken up into these groups for a discussion. So you have acute injuries, so those occur with some event, and then the injury takes place. Like at the time of the event takes place. So you twist the ankle, you sprain a ligament, or you break a bone. You get hit during a game, you rupture a ligament. You're playing and you pop it back again, you rupture Achilles while in the process of the event. Chronic injuries are like acute injuries that take longer than the expected period of time to recover. So if you've gone through the period of time that you expect injury to recover and he'll be given adequate treatment, and you're still having symptoms, we assess those as being chronic. Acute and chronic, there are those same acute injuries that became chronic, and then there's a flare-up, like somebody who had a hamstring strain and was being treated, or still having symptoms in the muscle, and then they continue to compete, and then they have another episode, so they have an acute and chronic injury. And then repetitive use injuries, and I'm specific in saying that because what used to be classically called overuse injuries, like stress fracture, etc., those are just as a result of doing the same activity over and over again, and a repetitive stress on the affected part of the body, which eventually fails over time. So these injuries are very subtle and oftentimes difficult to discern, and you need to have a discerning eye when assessing somebody for these issues. All right, so the medical intervention. So this is where what has been addressed as the background. As you figure, is non-surgical and surgical intervention. Non-surgical intervention, look at it in terms of, I might leave out some, but try to include in the talk. So orthotics, these are devices that you put into footwear and so forth to prevent and also to treat certain types of injuries, especially the chronic or repetitive use ones. Physical therapy, and these are all modes of physical therapy. I think in particular in terms of methods like ultrasound, tensile extent, magnetotherapy, shockwave therapy, etc. And then injections, and these are when we inject the injured area with certain substances, and these substances can either be biologic, which is where they are of the human species, I'm not saying just the species, but of your own body, and non-biologic, when this is some man-made product that is used to inject the area. So orthotics, like I say, usually it involves some kind of an assessment by the orthotist. Well, usually the initial assessment is done by the person that is seeing the patient, and some things are quite obvious. I mean, I probably have seen some of these slides before, but the image on the left shows somebody who has a flat foot, a flexible flat foot, and they're hyperpronate. So their Achilles tendon goes into valgus. The heel is in valgus, so the Achilles insertion is in valgus, which results in increased pull on the medial side of the tendon insertion of the calcaneus as opposed to lateral side. So the side is long and the side is overworked. That leads to overwork of the medial muscle group, in particular the medial head of the gastroc, can lead to cramps and strains that affect only the medial side of the gastroc, you know. So when this occurs, I mean, you have to treat the underlying injury, but in part of the treatment, while you're trying to rest, it involves using some kind of orthotic. In this case, is a heel wedge here. Or it can be a heel wedge that is molded into an orthotic that supports the medial longitudinal arch to improve, to correct the hyperpronation and the valgus deformity of the heel. This is just the picture on the right is that of a orthotic insert, which is an arch for arch support, and that is to help to treat certain chronic repetitive use conditions that can affect like the metatarsal bone. Sometimes just pain, which is just metatarsalgia, where you might just say stress reactions in the bone without any, when you do the MRIs, without signs of a fracture, you know. So such individuals that have foot pain, especially once they weight bearing, can be as, the pain can be as significant in terms of walking or just in training, etc. And in cases, especially when there's just a stress reaction, a medial longitudinal arch support fitted appropriately for the patient will help to reduce the repetitive stress on the bone, allow the bone to recover over time. All right, devices. All right, so for most patellar femoral conditions, whether it be patellar tendonitis, whether it be atrial tuberosity apophysitis, as you see in Osgood-Schlatter disease, whether it be a Sinding-Larsen-Johansson syndrome, which involves the attachment of the patellar ligament onto the inferior polar patella, or patellar femoral syndrome, where you have chondromalacia affecting both the cartilage on the back of the patella and of in the femoral condyle or femoral groove. Such situations, a patellar femoral strap is a good device to use. Mainly because, like I've mentioned before, what it does is it really increases the resting tone in the quadriceps muscle. So it's more of like a physiological type of device. It doesn't give much structural support, but by applying tension to the patellar ligament, you know, it's placed halfway between the tibial tuberosity and the inferior polar patella. When applying tension to the ligament here, it pulls on the quadriceps. So it increases the resting tone of the quadriceps, which increases its sensitivity and responsiveness to movement and any change in position. You know, that's why when you play this a sport that requires to move off, suddenly you go into like a 3/4 squat position. So your quadriceps is always engaged and ready to just push you off in the right direction. So the patellar tendon straps helps to improve that. Ankle foot orthotics or orthoses, in particular, like cam walkers, you have that the boot type, which is a short one here, and then you have that below knee type here. Those are good for ankle conditions, ankle sprains, in particular high ankle sprains that do not require surgery. So these are like grade 1 injuries of the ankle syndesmosis, which, as you remember, is a attachment of the joint made between the distal end of the fibula and the distal end of the tibia in your leg. And this joint is critical for the stability of your ankle, as opposed to a lateral ankle sprain, which really just involves the ligaments that are attached from the fibula to the talus and the calcaneus, which are really involved in preventing serious injury when your ankle inverts. The high ankle sprain is something that you don't send people back out for right away. You have to give them a period of rest, anywhere between 3 to 6 weeks. I usually protect them in ambulation, usually with some kind of a walk like this to allow it to heal. It's not as opposed to a lateral ankle sprain where you can actually pretty much just tape the ankle with athletic tape and send them back out onto the field, you know, to prevent them from going to inversion, because loading is not an issue. It's the twisting or the rolling of the ankle that becomes a problem. So those are devices used in non-surgical treatment of some of our sporting injuries. Knee immobilizers, and the knee immobilizer on the right has no hinge in it, just keeps the knee straight. That can be used to treat fractures, undisplaced fractures of the patella, and it kind of protect it for a period of time. It can be used to heal, to protect or to treat some ligaments injuries of the knee, lateral collateral and medial collateral ligaments, grade 1s and grade 2s in particular. But for those, we tend to prefer the device on the right, which is a hinge knee brace, which allows you to put the knee in a certain amount of flexion. And then you can mobilize the individual gradually after that. And usually we use this device for 4 to 6 weeks to allow the collateral ligaments of the knee to adequately heal. And then afterwards, once they've healed, usually if we're going to send them back into play after they've been adequately rehabilitated, they can, with these devices, especially the hinge knee brace, do like isometric type exercises for their quads and so forth during the period of time that they're in the brace, and other exercises for the other parts of the body. The good thing with these devices, as opposed to like a cast, that they're light and they're easily tolerated by the patient or by the athlete. And that's a big thing when you're choosing a device for an athlete, is that you want to use whatever it is that makes it most tolerable or easier for them to continue to train and work out the uninjured parts of their body. And that's where these devices come in play. You know, they can take them off when they go to shower, and then when they are engaged in activities, they can lift, they can exercise other parts of the body, they can do other activities with less hindrance from the device that's used. Injections. We had mentioned that injections can be, this thing give me a double tap each time, can be biologic. Biologic injections include blood, which was the start of all things, you know, before, right, when people used to have meniscal tears, we used to inject blood into the site of the tear, especially for the avascular part of the meniscus, the inner 1/3, and to a certain extent the middle third. You know, remember that the outer third of the meniscus has that known as the red zone, gets a pretty good blood supply. So from a long time, early days, we found that injecting blood into sites usually helps to enhance healing, especially in areas that are avascular. An advancement of this has been the development of PRP and stem cells injection, because they recognize that the healing part of blood is not really in the red blood cells. So then they start to spin it down, take the red blood cells off, and leave it with the plasma, which is rich in platelets, which has growth factors and interleukins and a variety of other compounds or substances that are what are critical in initiating healing of all parts of the body. You know, so getting rid of the red blood cells, that's what the key with PRP, and then stem cells, whether from blood or parts of the body, from body fat or from bone marrow, where they take the stem cells from, that's supposed to take it to another level where you have an omnipotent but pluripotent cells that can take on the characteristics of the cells in the area where it is injected. So inevitably you're trying to, instead of scar tissue, quote unquote, trying to develop virgin type tissue to the native tissue that is in the area where the injection is given. All right, this is after somebody who had a hamstring injury, a grade 2 tear that was injected with PRP. This is a little while after. This is the end of the muscle here. It's a muscular tendinous junction of the muscle. And here you can start to see organization of the PRP matrix, you know, and you can see more of that down here, you know, kind of bridging the gap between the injured and the uninjured part, you know, and eventually that should fill in with scar tissue. It's important when they get these injections that you start range of motion. Once we figure the clot has stabilized, and depending on what you use, that can be anywhere between 2 days and 2 weeks. And as you start range of motion exercises and not much resistance stuff, to reduce, optimize range of motion and flexibility of the muscle and to reduce the risk, the incidence of scarring. Now, non-biologics are generally used for either repetitive use injuries or chronic injuries when your main problem is pain. So there's really no structural issue. The main issue is pain, and really what you're trying to do is break the pain cycle so that the athlete can train without issue. And you classically see this in patients who have tendonitis of some form. It can be in the wrist, most of the wrist. Classically, things like plantar fasciitis, which can be considered tendonitis, like a ligament, well, not a tendonitis, but it's seen as a ligament, plantar fasciitis, sesamoiditis, especially of the great toe. You know, it stands for persons who like have flat feet and hyperpronate, where they put a lot of pressure on the ball or the great toe and the sesamoid bones there. They can end up with a sesamoiditis as well, which is just inflammation of the sesamoid bone, which just makes it extremely painful to walk on, sometimes run on, or just to push off on, especially like in a throw. So in a case where the issue is pain, right, especially some of these repetitive use or chronic problems, you do your MRI, in fact, the structure is intact and it's just inflammation around the area. A glucocorticosteroid injection is a good option to break the pain cycle. Critically, when you do this, though, sometimes people do it and they send the person straight back into the field. I tend to be very wary because remember that glucocorticosteroids do denature protein to a certain extent and do increase the risk of tendon or ligament rupture. So usually after the injection, there is a down period of time. And usually I take between 4 to 6 weeks before I allow the athlete to get back to full activity. That's allowed the tendon to go through the whole healing process and resolution to get back to its normal consistency after the injection. It is unwise to give a steroid injection because the patient athlete feels good to send them back out in the wild. That's a sure remedy for a rupture, and especially if you decide to give an injection in the peritendinous area of the Achilles or the patella ligament. You know, these very powerful anti-gravity muscles. If you go in that road, it's important. I strongly suggest you do that. We don't just so guide. It's not given in the tendon, it's given into the bursa around it, and that the person does not return to play immediately, but they wait at least 4 to 6 weeks until we're happy that the steroid has worked its way out and the tendon has regained its activity, its consistency. Just to note that, remember that since last year, glucocorticosteroid injections are now prohibited in competition. WADA has, and competition means from midnight the day of the competition that is in question. So you can actually do anything up to 11:59 p.m. the night before. Notice that all of these steroids have a washout period. So if they get something close enough within the washout period, make sure to mention it when they get drug tested, so that if it shows up and it falls within certain limits, they won't bother to harass you. If it doesn't, you're going to have to explain yourself. All right, so that's important for both athlete and treating individual when you're considering steroid injections. Or surgical intervention. All right, so I have a double tap thing. So these are things that relatively common things that we have had and done within the last year or months, you know, here in Mandeville, and I'm sure at other hospitals that practice orthopedics in the country. So tibials, I'll go through a few of the common things that we've gotten, you know, and of course there are a lot more that we won't get into, but generally rule of thumb, surgical intervention is indicated when there is a significant injury that you do not expect to be able to heal adequately without performing surgery. All right, so and this crosses between athletes and non-athletes as well, in the sense a lot of time, and people think that, oh, they're an athlete that you can find somewhere, do something to make them come back faster, or for the healing period that's supposed to be shorter, and that is not the case. So be very careful in trying to rush athletes back from intervention. Now, tibial spinal involvement is a relatively common problem we've had in adolescent athletes. Most of them have been football players and it usually involves some kind of a twisting injury to the knee that takes place during the course of the game. Usually followed by pain and swelling of the knee. It's oftentimes missed by the untrained eye. So that is why a lot of times when the athlete gets an injury, especially a knee injury, especially the skeletal immature, it'd be wise to have somebody else with an orthopedist take a look at it, because we've seen a lot of these things missed, and by the time they get to us, it's unwise to do anything surgical at that point in time. So the tibial spine is at in the middle of the tibia or the shin bone for those not medical inclined. It falls between the knee here. It's not on a weight-bearing surface of the knee, so it falls right in the femoral notch here. And here you can see it lifted up here. And when you look at it from the side, you can see classically where it is lifted up pretty significantly there. The issue with the tibial spine fracture is the ACL footprint. Now, classical, a lot when you get the tibial spine avulsion, usually it involves the anterior cruciate ligament footprint. It's attached to some part of it. If you see the extent of the footprint here, pretty much from the middle of the tibia to the front of the knee, when you look back at this image here, you can see here where this obviously involves the ACL footprint. And if you don't treat that, that's going to leave the athlete with a very unstable knee, which especially for pivoting sports like football, netball, basketball, etc., it becomes very critical, and it predisposes the athlete to increase risk of degenerative arthritis of the knee down the road. So that was a kid, one of the kids who had one. This is a CT scan of a different kid, as you can see when you can see from the image here. So the CT scan you can see shows the fragment, the spine fragment there. And this is one sagittal view. If when you go to the other views, you can see where it broadly involves the footprint. So usually individuals like that, they involve like some twisting injury of the knee, pain and swelling. Usually when the knee feels unstable, and if they try to continue playing, then the swelling gets more, and it usually gets worse. So usually they come off because of the symptoms. By surgery, what we do, this can either be done open or closed. We do always open because we haven't gotten our arthroscopic tower yet. And we go to the inside part of the middle part of the patella, we open it up, go down, identify the fracture, reduce, clean out the fracture site, reduce it, and then we pass a screw through it. There are multiple ways to do this. The solitary screw through the fragment here, you can see the fracture reduced down and back on the left of the tibia. The issue with using a solitary screw is that it goes through the growth plate, and it's believed that violation of the growth plate might lead to some growth arrest. However, this has not been shown to be the case for use of a solitary screw. If you're very nervous, you can go extra articular and do this. You can go extra articular. This use a short screw that just ends in a headless screw, which locks into just the epiphysis of the tibia and doesn't go across the growth plate. Or what we have done here in Manville a lot is use key wires, where we open it up, we visualize the fracture, reduce it, and we pass a wire above the growth plate and a direct vision and pass it into the spine. This is a non-weight bearing surface of the knee. So we pass it into the spine so we can see the tip of the wire. And we won't have fake movement because it's in the non-weight bearing surface of the knee, and usually these athletes go on and heal well. This kid was a footballer, but we've operated on middle distance runners. Most of the ones that we've operated on have been footballers. It's the same kid after screw removal, less than a year. I think we removed the screw at either 6 or 9 months. Fully healed, he had full range of motion when he came to the clinic. and was then referred for gradual return to sport. This is one that spares the face. This is one in a 7-year-old, where it's a headless screw. Notice the trajectory of the screw, and that is used here. Post-operative, they were usually immobilized for 6 weeks until it's healed, and then we start mobilization and then gradual return to sporting activities. Now, a couple is our tibial tuberosity avulsion. This is the skater mature. This is the part where the patellar ligament attaches. Powerful quads, developing bone. This can get pulled off. This is very mild. We've had those where it's pulled way off and the kneecap flies way up into the distal third of the thigh. And for this, we go in and we try to use one solitary screw to lock it down. This kid has another football player injured during a game. We did this screw it down. He hasn't had the screw removed yet, but he has full range of movement now. Now, I throw this in because this was a bit of a controversial case. A couple of years ago, this was a kid who had knee pain. He was like a 17-year-old kid. Like his faces are closed. And he was having knee pain when he was first seen. He was diagnosed with patellofemoral syndrome, referred for therapy and advised to come back in 6 weeks. Anyway, they defaulted for like 9 months and continued to have pain throughout the whole time. The pain had gotten progressively worse. Did the X-ray that showed this, which is loosened here in the proximal tibia, right up underneath the articular surface, well defined, which are classic signs of benign bone tumor. It's this lateral view from the side. You can see it right up on the articular surface here. When we did the MRI of his knee, you saw it was like no subchondral bone. So this is just waiting to collapse from weight bearing. You know, there's tumor there, there's just cartilage there, there's no bone there. So just by walking, you could have fractured this going down into the fracture side. And a kid like this once as well. So this one was benign, and a kid once who had a malignant tumor in the proximal tibia, eventually had the whole proximal tibia replaced. But this kind of benign tumor, and then the well-wishers, the wagon crew behind, helps us the old boys and peers and things talk about. I figured that football was his only way out of the life that he was in and so forth, and were suggesting that he play and complete the season and have surgery afterwards. So I got in a bit of a WhatsApp cussing chat battle with individuals on the chat group. Yeah, it really kind of annoyed me. All things considered, looking at the big picture, considering that if you're lucky, you play a sport to your 30s, mid-30s, and if you have the average lifespan of a Jamaican or 70-something, the rest of the half of your life, you have to find something to do. Easy to find something to do if you have a knee without degenerative arthritis. So eventually, good sense got the better of WhatsApp chatter, and we operated on him. Just went right over the tumor, went in, cleaned it out, created the sides, and then we packed it up with bone graft. This was him 6 months afterwards, showing well signs of incorporation. You can still tell a margin there, but most of the bone had taken, and critically, the articular surface had not collapsed, which was very grateful. And he eventually returned to football after a year or so, with a better chance of making it through life. This is a kid who has a 1-year history of knee pain and no trauma like that. So just activity related. That affected when he walk, but when he started to play and play for a while, he started to have pain in his knee. No swelling or anything like that. So this was more of a repetitive use. We didn't think of anything acute or anything structural. Because of the length of the history and so forth, like I say, it's always classic, especially in the adolescent, get an X-ray. There are some things that they have that the rest of us don't have. That is wise to investigate. Now, I've had a couple of these in the past. One was this is a footballer, had one with a track and field athlete one time who had made a national junior team. When we made a diagnosis, told him not to go, he was most upset, and so too were his relatives, this external psychological pressure. I don't know you can do what you want, but I strongly recommend that he didn't participate. But here, what you can see, this loosened area well demarcated, and the inside part of his medial femoral condyle does involve a lot of weight-bearing surfaces, why probably has managed to continue for such a long period of time and extends up into the notch on the non-weight-bearing surface. On the side view, you can see it there as well. A condition known as juvenile osteochondritis dissecans, believed to be either one of two things, either due to a developmental situation with the child growing up and that the bone doesn't fuse fully and properly, or a microtrauma situation where due to repetitive microtrauma, to the area is like a stress fracture to the subchondral bone, resulting in that defect. Now, this is an X-ray. It doesn't tell us, didn't see any sign of like a loose fragment in the joint. So my prayer is that the joint surface is intact and it's just the fracture line that is there. So it's been sent for an MRI. We haven't gotten that back yet, but I can just walk you through what we do in which case. So if it does the MRI and the MRI shows that the cartilage is intact and it just has the fracture line there, then it's a matter of no activity, no load and stuff, no sports for anywhere between 3 to 6 months to allow this to heal, because you want this to heal and get reincorporated into the bone. So usually we do the MRI and repeat MRI at 3 months to see that it is incorporated. And once it has healed, then we can talk about a gradual return to sport. If there's a hole in the cartilage and what is there is just really a bed of bone, and what we do is what we call a microfracture procedure, where we penetrate the bone and create bleeding. But blood is the start of all healing, the blood of Christ that was shed for you. So the blood, you create bleeding in the fractures in the bed of the defect, and that bleeding will initiate the formation of fiber cartilage into the area. Not hyaline cartilage, which which is better, but it's fiber cartilage, which is more resilient and so forth. So it will feel funny, but usually athletes are able to continue competing. If there's a loose fragment of bone which is off and in one of these way back in residency, then we can screw it back in place. We can use headless screws to screw it back in place, or if we use a screw with a head, we have to make sure we remove it when it has healed. There's no signs that this is loose. We're praying that the articular surface is intact. So we'll get the MRI, will make that judgment. So it will be non-operative, where we just, he's in a lot of pain, we mobilize him for a period of time, but no pain is just no strenuous activity for a period of time that you hope that it will take for it to get reincorporated into the bone. All right, so this is another kid who was treated with a prolonged history of back pain over a year. And a thrower like this way back in the day, who had one chance when he was in class 2, but was having significant back issues when he was in class 1. Eventually had done his x-rays. This is not his x-rays, and he had this picture here. So this kid is what, 14 or 15, present with a history of back pain, activity related, forget his event. When they examined him, he's tendon over the spinal process zone, right, the lumbar sacral junction, and his pain, no pain in flexion, but when he extends, pain, and when he laterally flexes, pain. Those are all signs of extension back pain, and lateral flexion back pain is all a sign of facet joint or posterior element pathology, So with the history and everything at the time period, I sent it for x-rays. I asked for oblique views, but then they hadn't done them, so kind of cuss and carry on, but the plain x-ray was quite obvious, so said we get a CT scan, which he hasn't gotten yet. But here, what you can see is that one, if you look at the full view of this lumbar sacral spine, it has a normal lordosis, which suggests that his pain wasn't that significant at the time. And if the pain is that significant that the paralumbar muscles go into spasm and result in the loss of the normal lumbar lordosis. So the preservation here of the normal lumbar lordosis suggests that the pain isn't that significant. Like I say, it's pain with activity related. When you look at the hone-in view here, that's the sacrum, that's the 5th lumbar vertebra. Look at the normal, this is the L3 here, look at the normal, that's the facet, the superior facet of the 3rd lumbar, that's the inferior facet of the 3rd lumbar. So they kind of form a nice line there. When you look at the 4th, you can see they form a nice line there. When you look at the 5th now, that's the superior facet of the 5th, and that's the inferior facet of the 5th. So they're not, there's no line. There's a pretty large step there, and there's a defect between it there. And that's the part between the articular surfaces known as the pars intra-articular iris, which is just the part between the articular surface. It's pretty significant. And that's known as a spondylolysis. Right? Classically, you just have a defect and you don't get the shift in the whole vertebra, which is known as spondylolisthesis. Spondylo meaning spine, to lys means to whatever, break down, and listhesis means to move. So you can see here where the fifth has moved forward on the sacrum. All right, so we've said for a CT scan, and then you may need an MRI to see what the activity, what the nature of the ends are. You know, i.e., is it active? Is there signs of edema or bleeding or something, which means that it might heal. Otherwise, so it will be activity modification for a period of time if we consider it is stable and has a good chance of healing. Otherwise, we do a single segment spinal fusion where we run pedicle screws in. And you don't necessarily have to reduce it. The idea is not necessarily to have to reduce it, but to promote fusion in situ. That's like a grade 1 listhesis. So it involves passing pedicle screws into the fifth lumbar vertebra, into the sacrum, and we attach bars at either side. And we usually pack some bone graft inside there to promote fusion. This will keep you up for at least 9 months to a year. You know, we want 3 months properly for the bone graft to properly incorporate into the area before you really start any major type of activities. My kid actually came back for his last year class when I made the final in both throws, and I mean, yeah, from a champion to a final. I mean, all these concepts he did pretty well, you know. But this kid here, we're waiting to get his CT scan and possibly the MRI after that. So, bereavement and Achilles tendon rupture. If you want to return to sports, primary repair is what is recommended. That's for complete rupture. It's an incomplete rupture. We also do recommend primary care if you plan to go back to full level sporting activity. If you're not on that end of the spectrum and you're just going around in life being lifeist, then we can treat the non-operative, which would be immobilization with a foot in the equinus for like 6 weeks. And usually incomplete rupture means less than 50%, less than half of the structure of the tendon. And sometimes you have to be careful because sometimes the ultrasound and the MRI reports can be deceiving, you know, because these things don't really tear clean, they kind of shear, you know, so you'll have fibers, ligament, tendon fibers overlapping each other, giving the idea that part of it is intact. But clinically, when you do the Thompson test, when you squeeze the calf, you get absolutely no movement of the ankle. You don't get any passive plantar flexion when you squeeze the gastrocsoleus complex, which clinically that is a complete rupture. If you do get some movement and the findings are consistent with that, then fine. But be careful. Remember to treat patients or treat athletes and don't treat images. Like have images that the thing is intact and you're squeezing the hell out of that gastrocsoleus complex and nothing is happening. You know, when you operate on it, you see that the whole thing is kind of shorn. And the rehab from Achilles is actually probably worse than ACL in terms of return to sport. Most people tell you to take 1 year fully to come back from an Achilles rupture. And if you follow any professional sports, a lot of basketball players have had this injury. Kevin Durant, Clay Thompson, a whole bunch of them have had Achilles tendon rupture. Kobe Bryant, I saw it happen. Most of them end up having to modify the nature of the game when they come back. So my primary repair reduces risk of recurrence. And most of these athletes, we've done about 6 this year alone. One of them was a badminton player. The rest of them were choreogoat or footballers. Playing them choreogoat football on the weekend, hear a classic story, hear a popping noise, that them get shot, them hear this noise, they don't feel anything. Because whatever reason, I guess a lot of sensory fibers are down there. They don't feel a lot of pain, but they just hear this popping sound and they're looking around to see if somebody fired a gun or they something hit something or whatever, and then they're unable to function after that, you know. I guess because they don't feel any pain, a lot of them feel like there's no major injury. When you examine them, Thompson test is positive, and then the imaging studies vary depending on the person performing them. But like I said, treat the athlete and not the thing. So I said that most of these were footballers. One was a badminton player, and the other person was a fitness instructor, actually, who they've done in the last year. ACL rupture. If it's less than 50%, you may consider non-operative treatment. That's a rupture of the anterior cruciate ligament. That's one of the main stabilizers of the knee joint, which is critical for pivoting sports. We said soccer, American football, rugby, netball, basketball, anything where you have to stop and pivot and shift. You really need a sound anterior cruciate ligament to do this, take part in this, volleyballers, etc. So if it's less than 50%, especially in the skeletal immature, you might try non-operative treatment, which is immobilizing for a period of time in anterior cruciate ligament type of brace to allow it to heal. Obviously, you want to do serial MRIs. So people might consider injecting PRP or stem cells in there during this period of time, and then you start the sequential rehabilitation. Once it's more than 50%, this is considered a complete rupture. If you're going to take part in a major pivoting sport, then you should have it reconstructed. If you're not, and you're involved in like cross country or something like that, you're just a recreational athlete, then you might choose to proceed with an ACL deficient knee, provided that you do the appropriate rehab in terms of your quad and your hamstring strength and so forth to stabilize, to strengthen the dynamic stabilizer of the knee to reduce further risk to injury for other structures. Injections for complete ruptures are found not to work. I'm familiar with several professional football players who have tried to go to centers and get injected with stem cells and so forth. But I've not seen one success story for them to be able to return to the level of sport that they were before. I should have had a slide before. Choice, you can choose autograft with you use a person's own native material, hamstrings or bone, patella tendon bone, which is my preference. The rehab is 9 months a year. Persons who have tried to come back faster than that in 6 months end up with some re-injury, and the studies, when you go to all the conferences with all the quote-unquote experts who have done many of these and do these, they tell you they are very aware of doing anything before 9 months to a year, and especially for the hamstring ones, because it's about the bone patella ligament, bone preparation. At least you have bone and bone healing at the tibial and the femoral side. But in the hamstring ones, it's a soft tissue to bone healing at both ends. And so the most of your experts will want to wait a year before they try to return you to sport-specific activities. Well, to return you to play. You're doing all of necessary rehab during that period of time. In stepwise fashion, you do the necessary. So that's just two athletes that we have treated in the region, both not opportunity, fortunately. All right, so in summary, sporting injuries are common. If you're going to play a sport, high chance you will get injured some way before, whether you're playing it at a high level or you're playing it at a corrugate level. Preventive approach is crucial. It's crucial in reducing the risk of injury. And these are specific training methods to reduce the risk of injury that is particular for your sport. So like again, as if a lunging athlete, strengthen your ankle stabilizers, make sure they strengthen ankle stabilizers. I do, because the other thing as well is that in terms of extrinsic factors like shoes, surfaces and so forth and thing, if court shoes, like for a lot of court sports, badminton in particular, are designed, volleyball are designed for hardwood or suspended board floors, which are softer than concrete, which is what most of us play on. And it's almost counterproductive if you're using a court shoe on a concrete surface, because you're at high risk for developing repetitive use issues to the bones of your feet, stress fractures in metatarsal bones, etc., sesamoid problems, etc. So for those situations where you don't have the ideal surface to play on, you're probably better off playing in something like a cross trainer, which is a little bit higher than a court shoe, and so increase the risk of your ankle rolling over. So try to use appropriate shoes for court services, shoes that reduce low profile shoes, which reduce risk of ankle turning. But to back that up, you want the ankle strengthening exercises, which I still do to reduce my risk. I play in a cross trainer when I play badminton, and I do my ankle strength exercise on a regular basis to reduce my risk of a major ankle turn. And so far, it has worked. As a physician or a treating, be diligent in making the right diagnosis. There are a lot of good physical therapists outside there. And a lot of times, they're the first person that the athlete sees, especially in high school sports and professional sports to a certain extent. And most times, most injuries are common. But the intuitive physiotherapists realize if they're treating a particular injury after a period of time, and they realize it's not getting better, they're going to say, listen here, they need to step it up and get another opinion, usually from an orthopedic surgeon, to determine is this what we think it is or what they said it is. And sometimes it is, oftentimes it's not, in which case the treatment is redirected. Yeah, we have surgical and non-surgical types of medical intervention. Choose your option wisely depending on the individual, the sport they play, and what's that they hope to do afterwards. And do not be pressured by individuals, well-wishers, wagon typers, WhatsAppers, who are pressuring you to try to get the athlete back to play before their time. Right? You can't, I always tell athletes that they go, you can't cheat God. If it takes 3 months for something to adequately heal, and for you to, it takes 6 months for you to get back to the thing there, that's what it's going to take. Take your time, get back there, rehab, and get back there. Don't try to short-circuit it. And I've seen from professional sports, major players trying to get back before their time and end up with some major other complication and issues down the road. You know, and if you follow a lot of them, you follow in professional sports, you recognize that you can't come back before your time without being properly rehabilitated. So treat appropriately and rehabilitate appropriately according to the injury. Do not try to rush the process. These are some of the references. I left out a whole bunch of them. That's which I'll enter at some other point in time. And that's it. Thank you very much.
Thank you, Dr. Jones. Thank you for the wealth of information. I'm pretty sure that everyone is appreciative of what was said. I'm very appreciative of the cultural context in which you presented as well. And I'm pretty sure that our viewers are able to understand and appreciate what was said. In the interest of time, we will ask if there is any question for Dr. Jones. You may raise your hand or you may type in the chat. I have a question for you, Dr. Jones.
Yes, sir.
While listening to your presentation.
My rant?
Yeah, and you're hinted on a few things. But, you know, as an orthopedic surgeon and a coach, you have been interactive with athletes right across Jamaica. And what I want to know is, what is the most common injury that you have encountered in youth sport? It doesn't have to be track and field or football, but based on, because I know you work with a range of events. What, in your estimation, what is the most common one that you see?
Most common is what's common, hamstring injuries. That's probably the most common injury that I've seen in different ways of form. And they've had to operate on any of them. A lot of the ones that I've seen have come in with predisposing factors. The two main ones, poor flexibility. And you check flexibility. So flex the hip to 90 degrees, while supine, flex the hip to 90 degrees and try and extend the knee. So you're trying to mimic the sprinting action. Knee lift and then, so hip flexion and then knee extension at a rapid explosive pace. And if that is poor and unable to get to 90 degrees with hip flex 90, that's an increased risk of injury. And then also hamstring quad imbalance. Like I said, I've said the story about an athlete eventually went up to make it at higher level and done extremely well, who was having hamstring issues, changed camps and everything because wasn't being well according to him, was being adequately getting the appropriate attention from the camp he was in and whatever. But anyway, measured him and his hamstrings were extremely weak compared to his quad. Put him on a program, and he eventually went on to become a champion at different levels. So hamstring injuries, and usually most of them are predisposed either from inflexibility or hamstring quad imbalance. And then next to that would be knee injuries in some way or form. I showed the ones that we the fracture, the tibial spine, the tibial tuberosity avulsion, but repetitive use knee injuries, patellofemoral syndrome, most of the times due to lateral maltracking of the patella. Repetitive use issues like Osgood-Schlasser disease, extremely common, so, and that's a tibial tuberosity apophysitis for those that are not familiar. And so those are the more common ones that I see. You do get the other main injuries. We've had footballers come with open fractures of their tibias, which we've had to fix. We've had a couple of fracture femurs, which we've operated and put nails on, but those are not common. Common things, hamstring injuries and repetitive use problems such as around the knee, Osgood-Schlatter's, and various tendinitis around the knee.
Okay. I'm seeing in the chat that we have a question from Annika Harvey.
Right.
And Annika asked, Dr. Jones, what's the most common boxing-related injury? And have you treated any in recent years?
Boxing. So don't see a lot of boxers down this side, but formal boxers. The informal ones, the people that get into fights, of course, are fractures to the necks of the metacarpals. Boxers as a whole, head injury is what we're most concerned about. Concussion, that is not just being knocked out. A head injury or concussion is not loss of consciousness, but it's impaired cerebral function. And that can just mean the person being unbalanced, being slow, some memory issue, whatever, without being knocked out. So that's probably the most that I'm aware of common injury in boxing, and one that has, gained a lot of attention over the years. Apart from that, has been injuries to the hands, like I said, non-professional boxers, amateurs boxing, metacarpal fractures, and then wrist sprains, from repetitive load or some abnormal loading event that took place in the wrist during a fight. So those are the kind of some, but don't see a lot of them professionally, but those are the ones that in fact are more common with the boxers.
All right. Thank you, Dr. Jones. For the interest of time, we will.
That's another one from John Campbell.
You have another question?
Yeah, from John Campbell.
Okay.
Is there a significant difference between plantar fasciitis and heel spur or painful heel? There's a difference between the nature of the condition.
All right, so a heel spur is an anatomical condition, right? Plantar fasciitis is a functional or physiological problem. Right? So a heel spur, remember 50% of persons who have plantar fasciitis have a heel spur. So I mean 50% of persons do not. So one of the big problems and one of the things that kind of gets on the nerves of orthopedic surgeons a lot of the time, people come and say, oh, they have a heel spur, one of our famous US president talked about having bone spurs. Bone spurs, the truth, are not the issue. Is that what is attached is the plantar fasciitis. You can have bone spurs and you don't have plantar fasciitis. Plantar fasciitis is what causes the impairment, causes the pain and the impairment. So plantar fasciitis is a chronic inflammatory condition which affects the plantar fascia, which in essence is a ligament which attaches from the heel to the toes, and is a major structural support of your medial longitudinal artery, your foot. So every time you plant, it tugs at the back of the heel, right? So most individuals will develop a traction spur where the plantar fascia is attached. Remember, so also there are flexor muscles in the foot that are attached here. And just pulling at any developing bone over your lifetime will result in a spur forming along the pull of that ligament, tendon, or muscle. Okay? So we don't treat bone spur. We don't go in and take out bone spurs. We treat plantar fasciitis.
Okay, we have another question. One more question, Dr. Jones. This is from Mr. Teron Brown. Good day. Have a knee pain, no swelling, just pain. Only when flexing the foot, I feel pain. How to treat it?
All right. So very vague flexing, and I assume by foot it means flexing the knee. Right, and that's very straight.
There's that. Yes.
So depending on how old a person is, but usually a skeletally mature individual with knee pain caused by flexion, deep flexion, in particular squatting, that's usually some kind of a degenerative meniscus issue. Right? And generally degenerative meniscus issues are treated with therapy. You know, strengthen the quads and strengthen the quads in particular, but usually treated with therapy. For meniscal injuries on a whole, the bone cause swelling or the swelling occurs, especially degenerative types, the swelling occurs hours or even a day after you participate in a sport. And you have to ice it down, you're finally able to go back. But you just find this condition being recurrent. And it usually only affects you in deep flexion. And that's because when you load, that's when the femoral canals really come down and roll on the tibial plateau and the menisci to cause pressure and those symptoms. Once you're not having locking, it's therapy or training exercise. So like icing after every activity and the therapy to strengthen the various muscles that support the knee joint.
Okay, thank you. I think that is it for Dr. Jones. Dr. Jones, thank you again for your support. Thank you.
You're welcome. You're welcome.
Doc, you definitely play more than just a substitute. So thank you very much.
All right, I've already done it, so you don't have to kiss up to it. I've already done it, so it's too late now. All right, cool.
Right, so we are now moving on to a sponsored presentation by Medicomplex, and it is a video feature, and Dr. Brown will initiate.
Right, 1 second, let me just bring it up again. I had it a while ago. So I'm going to go ahead and share screen, bring it up. Right. All right, should be able to play now. So it's a pre-recorded presentation, so we'll just listen and then we have Q&A afterwards. Or Mrs. Cheyenne Megu, she'll field questions afterwards.
Greetings, everyone. I am Cheyenne Megu, representing Medimpex Jamaica Limited, where we provide first-class products for healthy living. In keeping with the topic or the theme for today, I'll be presenting on our orthopedic support line called ProTech. ProTech provides great quality and affordable products for pharmacies and sports professionals, and we continue to constantly add new products to our catalog. We also develop and source new innovative products. Our ProTech orthopedic supports provide support for sprains, strains, weakened muscles, and they also help to reduce further injury. They also provide compression that can help to reduce swelling of injured muscles and joints, and they provide therapeutic warmth. So in this line of products, we have two types. We have the elasticated products and the neoprene products. So I'll be going through a few of our elasticated products. For the elasticated products, they are breathable, lightweight, they provide mild compression and also rehabilitation. They can be worn all day and they can be used in sports. Starting with our elasticated knee support. It provides a four-way stretch, mild compression, lightweight, and breathable, as I mentioned before. It's indicated for minor sprains and strains, arthritis, and for prevention of further injury. Next, we have the elasticated ankle support. It also provides a four-way stretch, mild compression, lightweight, and breathable. Indications are as listed before: minor sprains and strains, arthritis, and prevention of further injury. Next, we have the elasticated elbow support. Also provides a four-way stretch, mild compression, lightweight, and breathable, and the indications are as listed before. We also have the elasticated hand support, and along with the indications listed before, it is also indicated for use in repetitive strain injury. The elasticated wrist support is another product in this line, and unlike the others, it has a two-way stretch and adjustable compression. It has the hook and loop fitting, and it's indicated for minor sprains and strains, arthritis, and prevention of further injury. Next, we have the posture support, and the posture support has an adjustable fit. It can be worn under clothes, and it provides mild compression. It's unisex, and it helps to maintain a good upper back and shoulder posture, and it can help to activate the muscles needed to correct bad posture. Also available is the elasticated back support, which provides a two-way stretch, dual belt system, and it is adjustable with the hook and loop fitting. It is indicated for minor back pain, abdominal sprains, and also to support weakened and injured back. One of the newest products added to this line is the tech tape, or the kinesiology tape. It has a super sticky adhesive. It provides extra flex and movement. It's breathable and waterproof, and it can be worn for up to 3 to 5 days. It can be used on the shoulder, upper and lower back, elbow, wrist, and groin, just to name a few. Indicated for use in muscle and ligament injuries, can be used for sports injuries, and for enhanced performance. Now moving on to our second type of orthopedic supports, or neoprene protect products. The neoprene products provides heat retention, and they provide moderate compression as well as rehabilitation, can be used all day and used in sport. Starting with the neoprene knee supports. This one has a closed patella, and as mentioned before, it provides moderate compression, heat retention, and it can be indicated for use in sprains and strains, arthritis, and prevention of further injury. Next, we have the neoprene open patella knee support, which, as the name suggests, it has an open patella, also provides heat retention and moderate compression, and along with the other indications listed for the closed patella knee support, it also can be indicated for patella stabilization as well as for prevention of patellar displacement. Moving on to our neoprene knee stabilizer. This one has a firm compression, or provides firm compression. It has 4 metal stabilizers. It has the hook and loop fitting, and it provides heat retention as the others do. Along with the indications listed before, it's indicated for structured support to reinforce the knee joint. Next, we have the neoprene ankle support. This one provides moderate compression as well as heat retention, and this one has an open heel. Indications include sprains and strains, arthritis, and prevention of further injury. We also have the elbow support, neoprene elbow support, which provides heat retention and moderate compression as well. Indications are as listed before. Moving on to our neoprene hand support, which has an adjustable compression, the hook and loop fitting, and it provides heat retention as well. Indicated for sprains and strains, arthritis, and repetitive strain injury. We also have the breathable wrist splints. This has 2 splints, and it is reversible, as it can be used on both the left and the right wrist. It is lightweight and also breathable. It is indicated for use in carpal tunnel syndrome, for weakened and post-cast wrists, and for repetitive strain injury. We also have the neoprene thumb brace. This also has 2 removable splints. It is reversible, can fit both the left and the right thumb. It has adjustable compression, and it's indicated for weakened or injured thumb along with repetitive strain injury. Also available is the neoprene finger splint, which provides moderate compression. It has an adjustable hook and loop fitting straps, and it reduces the movement to aid in healing, indicated for support in painful and injured finger. Next, we have the soft foam neck collar. It provides moderate support and it has an adjustable fit, indicated for minor neck injuries, pain associated with weak or injured neck, and it helps to immobilize area or prevent further injury. We also have the pouch arm sling, and this is available in the adult size or the junior size. It has an adjustable fit and it provides mild support, indicated for use in those with post-cast or post-surgery arm, and it helps to support or elevate the arm to aid in healing and prevent further injury. Finally, we have the reusable hot and cold pack, which comes with an adjustable fitting pouch. It's indicated the heat for aching muscles and stiffness, and the cold for pain relief or swelling, and it can also be used in sports injuries. So this is the price list for the orthopedic supports, and they range from $375 plus tax up to $2,499 plus tax for the most expensive one from us. Thank you for your attention. Do enjoy the rest of your day.
Thank you, Dr. Brown. Is there any questions regarding the products just being shown a while ago?
Well, let me just confirm, is Mrs. Magoo still there from Medimpex?
Yes, I'm here.
Okay. All right, so we're open to any questions for Mrs. Magoo. I think her presentation kind of tied in nicely to Dr. Jones's presentation based on what he spoke about. So any questions from anyone?
Yes, there's a raised hand.
Yeah.
Audrey McIntosh. Miss McIntosh, you can go ahead. Audrey.
Oh,
It's the same question as in the chat. Availability, where can we get the products?
oh, right. 2 questions about available in pharmacies. Ms. Magoo?
So most pharmacies island-wide has the products available.
All right. I'm seeing a request. Can you put up your address for Medimpex, and can it be ordered online?
It cannot be ordered online, but we have a telephone number that you can call. The address, I don't have it to put up, but it's 21 Balmoral Avenue, Kingston. And I can give you the telephone number now, so you can jot it down, or I can send it to the chat.
Yes.
So it's 929. Do you want me to send it to the chat?
Yes, please.
All right, no problem. So I'll send the address as well as the number to the chat.
And you said they're available in most pharmacies.
Yes, they are.
Okay. All righty. Any other questions for Medimpex or Mrs. Magoo?
No, I'm not seeing.
Not any more questions. All right. So I suppose we can move on. So Mrs. Magoo, thank you very much, and we thank our Medimpex for participating and for your sponsorship.
Okay, thank you very much for having us.
All right. You're welcome.
All right, we move quickly to our next speaker. Her name is Dr. Piet Brissett. She has been a physiotherapist for almost 20 years with experience in both acute and chronic patient care. She received her Bachelor's of Science in Physical Therapy with honors from the University of West Indies in 2004, a Master's in Science and exercise medicine with merit from the University of Nottingham in 2007, and her doctorate in physical therapy from Nova Southeastern University in Florida in 2013. She is a former teaching assistant at the School of Physical Therapy, University Mona campus, and a past lecturer in athletic training at the University of Technology, Jamaica. Her main areas of practice are orthopedic, musculoskeletal physical therapy, sports medicine, Pilates-based rehabilitation, and teaching Pilates classes. Wendy is a current public relation officer and executive of the Jamaica Association of Sports Medicine and the Jamaica Physiotherapy Association, and has worked with and traveled as team physiotherapist for different sporting organizations, including the Jamaica Olympic Association, Jamaica Athletics Administration Association, or J3As, and Netball Jamaica. Being with the latter for 15 years, she enjoys watching sports, traveling, and hiking. Please welcome Miss Wendy Peard Brissett.
Hi, good afternoon, everyone. Thank you for that introduction, Fabian. I'll just correct you. It's actually pronounced Pilates, and you're going to learn a lot about it right now. All right. So I've been asked to speak about Pilates and the athlete. I hope, is everyone seeing my screen?
Not as yet. I'm seeing you, but I'm not seeing your shared screen as yet.
Hold on a second. Let me see if I am sharing my screen. There.
It's coming up now.
Yeah.
Yeah.
Okay. All right. Okay. So, I'm trying to get onto full screen. There. All right. So we're seeing it now?
Yes, we are.
Yeah. Okay. So we're going to talk a little bit about Pilates. First of all, we're going to do a little introduction just to get those who are not familiar with the art and the practice of Pilates up to speed on how it came about and what it is. We're going to look at the principles, the guiding principles of Pilates. Then we're going to look briefly at the apparatus, so the machines that are used in the practice of Pilates. And then we're going to see how the principles of Pilates can be adapted to treating athletes and how it can help in their performance in sport. All right, so what is Pilates? It is a system of exercises that was developed by a German-born physical trainer, Joseph Pilates. He was born in 1983. It was first called contrology and was really intended to strengthen first the mind and then using the mind to actually control the body. It came to life during World War I when Mr. Pilates was asked to come back to Germany. He had moved to England briefly prior to World War I to help to treat persons who were injured during the war. And he actually rigged up beds using springs for exercises for the persons who were injured during the war and were unable to move around. In 1925, Joseph Pilates actually moved to the US with his wife and opened a Pilates studio in New York. And over the years, he worked with a lot of professional dancers and doctors, and he started getting lots of referrals from orthopedic surgeons to help with persons to regain their function. So this is a picture of Mr. Pilates, well into his 80s. He died at 83, but he was very active all throughout his life. And this was him in his latter years. As a young man, as a child, actually, he suffered from asthma. He had rickets, he had scoliosis and rheumatic fever. But he believed that an unhealthy lifestyle was attributed to poor breathing, bad posture. And so he decided that to make it his life's work to help persons get better by treating their posture, helping with their breathing, and helping to improve their lifestyle. So this was him as a young man. This is a picture of the first Pilates studio that was opened in New York City in 1925 with his wife, Clara. And as mentioned before, he worked a lot with professional dancers who, you know, have to work a lot on posture, flexibility, and definitely strength and endurance. All right, so the 6 main principles of Pilates are breathing, centering, focus on using the core, control, flow, precision, and concentration. And we'll just go through each of these quickly. With regards to breathing, he believed that awareness of breath was very important to relax the mover, to center the mover, and also to organize the mover. And when we speak about organization, we're talking about proper alignment, proper engagement of muscles in order to achieve the desired movement. Synchronizing breath with movement helped to nourish the body with oxygen during activity, and this would improve the efficiency of the movement and also stamina to complete the activity. So one of the most common instructions you'll hear in Pilates is inhale to prepare and then exhale on the movement. And we know that's common, where you need to breathe out as you move to allow the body to be nourished by oxygen. All right, so this is just an example of what happens during exercise. Breath facilitates spine stabilization. So with breathing, we're encouraging the connection between the diaphragm, the transversus abdominis, and the pelvic floor to create an environment that supports vital organs. Give me 1 second. Mommy. My apologies for that. I will return to my presentation. I'm sorry about that. All right. All right. Are we seeing Fabian? Are we back on?
Yes, we are.
My apologies. Right. So breath helps to facilitate spine stabilization, and that's usually done through engagement of the core. So we're looking at a connection between your diaphragm, your transversus abdominis, and the pelvic floor muscles to create an environment that supports the organs and creates axial elongation of the spine. And that is very crucial in Pilates because that ties in very well with posture, which is one of the mainstays of practicing Pilates. So an example of how your breath can help with movement, here we see someone holding on to a bar, but the actual exercise, the aim of the exercise here is to facilitate movement of the scapula. So with an inhalation, we can elevate, protract the scapula and internally rotate, but the actual aim that we want to achieve is to get scapular retraction. So with an exhalation, we can guide a patient or a client to retract the scapula, depress the scapula, and externally rotate the humerus, which will in turn open the chest up and improve over time posture. The second principle is centering. Now, the core is known as the powerhouse of the body. So your core muscles are used to stabilize your trunk and pelvis, and that improves flexibility of the limbs, which can help with technique. And athletes need to be able to stabilize and move their extremities very well. It is a vehicle, the core is a vehicle to transfer force from the lower body to the upper body. And this dissipation of energy through the core can be minimized, and that allows for more power potential and more efficiency. Lower back and other injuries, which are very common, can be prevented with a stronger core and a more efficient trunk. The muscles of the trunk control our pelvis. So if there's poor control of the trunk, that can contribute to hip, knee, and ankle injuries, among others. And finally, the core has to be recruited in order to perform athletic movements efficiently. So if you think about a swimmer going to do freestyle, so they're streamlined in the water. So with a nice strong core, they're able to maintain an elongated spine, and that will help with their hip extension to kick and also their ability to get those arms out over the water and pull. All right, so just a video here showing a little bit of the kind of core work that can be done during a Pilates session. So if you notice, We have our upper extremities working as well as our lower extremities. A ball is placed in position to help to recruit those transversus abdominis muscles, those inner thigh muscles, your pelvic floor muscles, and we're having a nice stable spine to work with. Similarly, we can change positions. We can get the same activity achieved. But in a kneeling position, which then recruits your muscles for balance. So you're looking at your gluteus muscles, your hamstring muscles. And with this exercise, we're working on an eccentric contraction of your abdominal muscles, as well as your hip flexors and your quadricep muscles. So again, working on stabilizing the spine, engaging the core, using different positions and using different methods of movement. So the core is very important in dynamic stabilization, moving your extremities on a nice stable spine, as well as functional re-education, where you're thinking about getting back into movement, getting back into daily activities. A study by O'Sullivan et al. In 1997 showed that lumbar instability, segmental instability, was associated with motor dysfunction. Right, and that will inhibit how we move and the efficiency with which we move, and also pain. So a stable spine will in fact help with our motor function. Motor functional re-education, we're looking at functional activities such as squatting. If you think about having to do hip flexion with knee flexion and dorsiflexion, that does not necessarily have to include flexion of the spine. And so these are some of the principles that we try to implement during sessions. We want to maintain nice axial elongation of the trunk while doing basic activities, even walking. Sometimes we'll find that when we're walking, we tend to be looking down a lot. So nowadays, everybody's on their phones, that kind of a thing. And so that leads to a lot of cervical flexion, that leads to a lot of shoulder elevation, thoracic spine flexion, and all of those things over time leads to pain. So we have neck pain, but the neck pain is really associated with an inflexible thoracic spine, for instance. So looking on these small little details and trying to address them during treatment can actually help functionally over time. The third principle is control. Now, I mentioned before that Pilates was originally called contrology, and it really involves the use of the mind in order to perform your exercises correctly. It really requires a strong mind-body connection. And this is interesting because a lot of times when persons do Pilates for the first time, and you say, for instance, lift your toes, and 9 times out of 10, people lift their heels. And it's really because they're not very in tune with their bodies. Not that they don't know that they have a hand or a leg or a foot, but in terms of how to move your body and move your body efficiently, a lot of times persons don't realize that they don't know how to do that. And so learning how to control your body using your mind is extremely important. Every movement during a Pilates session requires complete control of your body in order for it to be done correctly. And your Pilates equipment, which we'll look at shortly, is designed specifically to help to control movement. So we have smooth gliding of the springs and pulleys, which are the main source of resistance during the exercise. And controlling movement is very important to restore healthy movement patterns, because a lot of times persons have compensatory movements that they use to mask the fact that they're not able to do something correctly. So an example of this would be somebody, for instance, with a Trendelenburg gait. So when you think about weak glute medius muscles, and every time they stand on one leg, the opposite hip falls. And to compensate for that falling of the hip, once they're standing on the stronger leg, you'll see a lateral flexion of the trunk, and that's usually used to help to bring the weaker leg forward. So those are compensatory movements that can be identified and eliminated with assessment and with treatment. So for instance, here we have maximum use of balance. You're on a very small surface and you're on a moving platform. So with being able to use your core muscles, you can actually extend this back leg further, pull it in, or bend this front knee and extend it. And that requires a lot of control, and it requires a lot of stabilization and concentration. All right, another principle that's very important as well is flow. So moving the body with fluidity and ease through all exercises, movements, and daily function. The emphasis is on graceful movements. Remember, we spoke about earlier that some of the earliest Pilates clients or patients were ballet dancers. And so there was a great emphasis on graceful and fluid movements. And this is essential for the body to move in a biomechanically optimal way. Right? And it involves coordination of different parts of the body for efficient and effective movement. With flow, you're looking at distributing forces evenly through the spine. You're looking at moving efficiently in terms of not over-recruiting in one area and not using another. So I can give you an example. A lot of times when we tell a patient to do a bridge, so a simple bridge lying on your back and curling the pelvis in to lift up to recruit your hamstrings and glutes. A lot of times we'll get persons bearing down through their shoulders, and then we'll get a lot of ankle dorsiflexion, and then we get a lot of diaphragm activation, so pulling in of the breath instead of slowly curling the pelvis in and gradually recruiting your hamstring and glute muscles in order to perform the exercise correctly. And with flow of movement, you get a better increase in your performance. So think about sitting to standing. Most people will stand up by going into great trunk flexion and then using momentum to push them up into standing versus recruiting your back extensors, your hip extensors, and knee extensors to push you straight up. All right, so principle number 5 is precision. So not only do you require a lot of flow and a lot of core activation, the movements have to be quite precise. And they're very subtle, but they're very, very, very precise movements because this emphasizes correct movement patterns. So emphasis on perfect technique and movement are necessary to move away from incorrect movement patterns. This is how we can re-educate the body to move properly. Precision requires initiating movements with the correct muscles and using them appropriately throughout the exercise. And this can translate into your day-to-day activities. So with precision, we're focusing on posture and alignment. We're focusing on using only what we need to use and only use it as much as necessary or as little as possible. And you'll see what I mean later on. It's also biomechanically safer when your movements are more precise because it reduces tension. For instance, your shoulder muscles. So a lot of times we find persons walking around and their shoulders are up against their ears, right? And this a lot of times happens because this is normal for you. A lot of people use this as a compensatory mechanism as well. So for instance, with Pilates, and I'll show you a video here, we can teach persons how to depress their scapula, and help more with trunk extension in their thoracic spine, which can help to elongate the neck and reduce tension in the upper trapezius muscles. So again, precision of movement. So we get alignment going all the way through the spine, all the way down to the heel. We've now extended the elbows. And if you're seeing, there's very slight movement here, and this movement is taking place just around the scapula. All right. And then we're going to go into just a little bit of thoracic spine extension. And with this, we're looking at depressing the scapula, lifting ourselves up slowly, but maintaining alignment of the neck and thoracic spine. And then on the release from that extension, we still maintain depression of the scapula without those shoulders hiking up towards the ears. All right. So we mentioned about alignment. It's very important how we position ourselves during the exercise. And we know persons have different alignments. You have valgus knees, you have varus knees, and Pilates can accommodate for that. We do accommodate for persons who are at different stages of their rehabilitation. So we can have closed chain exercises, open chain exercises, and pseudo closed chain exercises. So for instance, a closed chain exercise where we look at alignment of the hip, the knee, the ankles, and the toes, are using the feet on the bar of the reformer, which we'll speak about. And this allows for us to work on alignment. A lot of times when persons have their feet on the bars, you'll find that the toes turn out because there's external rotation at the hip, and this is just natural for them, which, you know, can lead to tight external rotators at the hip, and that can pull on the low back as well. Or sometimes we have internal rotation at the hip, so the toes tend to turn in, and this is natural. So by finding their correct alignment, we can then, or finding their natural alignment, we can then work on positioning and teaching them how to recruit the correct muscles to get the alignment that we desire. So an example of an open chain exercise is by using springs with no weight, but again, we can still work on positioning of the spine, contracting those abdominals, keeping that spine nice and relaxed in a neutral position while working through your hips, your knees, and your ankles. And this is good for patients who are clients who are non-weight bearing, so early rehab status, or persons who have very painful backs, learning how to recruit their abdominals and stabilize their spine. Pseudo closed chain activities, so partial weight bearing here. So not a lot of weight is being put down through the foot, but once they are able to, then they can start movement through the hip, the knee, and the ankle. And again, emphasis is on maintaining a nice straight spine, thoracic spine, and neck. And the last principle is concentration. So we spoke about that mind-body connection that's very important. If you notice with all the videos you've seen so far, there's always an instructor working with the client. And that's because the exercises have to be described and prescribed as the session goes along. So it requires you to focus and to be mindful of what it is that you're doing. So it requires a lot of focus and concentration. It focuses on movements and exercises that increase body and postural awareness. And postural awareness, as you know, is super important for daily tasks. It strengthens, as I said, your mind-body connection. So you becoming more aware of what your body is doing and whether they're doing the right thing or the wrong thing. All right. So over time, I find that once I emphasize certain things, a lot of patients who tend to sit with their shoulders rounded and always hunched, you know, they become more aware of thoracic extension, of lifting the chest, of opening the chest and tucking that chin in. So cueing and instruction is very important because you become more in tune with the areas of the body that need to be engaged, relaxed, lifted, lowered, straightened, or bent, all in one exercise. And that over time helps to reinforce things that need to be done during daily life. And this kind of mindful movement also helps with your pain management and your stress levels. All right, and very important, all of these things help with movement integration, and this is where the magic happens. So once you're now more aware of your body, you're more able to focus and concentrate on what your body is doing, being more aware of where your body is in space, then the pelvis, the thorax, the head, and the extremities can all work together as a whole. And this is where we can acquire advanced motor skills and also coordination of activities. All right, so you've seen some snippets of what's been happening in terms of Pilates. So just a brief overview of some of the apparatus that is used. So we call this a Cadillac or a trapeze table, and it has springs. There are loops here for springs to be attached, as well as a bar here that can be attached by springs, and that can provide resistance. This is what we call a reformer or tower combination. So right now, this is a tower. So it's actually similar to the trapeze table, except it doesn't have the bars at the top. And springs and straps can be attached onto the tower, and it can be used by the patient or client who will be on the table. This machine can be converted to a reformer, as you see here. And this is the moving apparatus that you see most persons on. The Pilates apparatus also includes the mat, and the mat I find is one of the hardest pieces of equipment to work with because there's no assistance, there's no help from springs, there's no movement from a machine, it's only you and your body. Other smaller apparatus that are used, we have a spine corrector. We call it a spine corrector, and literally that's what it does. It helps to correct the position of your spine. So here we have side lying. You can also lie over this on your back. So as you can imagine, that will help to increase thoracic extension. This is what we call a jump board. And I'll show you a quick video here. And this can be used for more plyometric type activities as well. And inside lying here, again, you're focusing on alignment and posture, keeping that hip, knee, and ankle in line while stabilizing the spine and the abs and the core. And then here we have a chair. It's a Munda chair it's called. And this one, as you can see, it's a lot smaller, no devices to help you. So this one is very important for balance training. Other props that can be used in Pilates are balls, as you saw in one of the earlier videos. This is a Pilates ring. The ring actually has a resistance material in there, so it actually provides resistance when you try to squeeze it using these padded areas. And these are some of the springs and TheraBands that we can use during the activity. And foam rollers as well, which everybody knows what a foam roller looks like. We can use those to enhance an activity and make it a little bit more difficult by getting the clients to lie on the foam roller while moving their arms and legs with the springs. So of course, that's advanced movement. All right, so how does all of this tie in to athletes? So essential components for a successful athlete are core strength, postural awareness, general strength, balance and proprioception, coordination, flexibility, endurance, power in some cases. They need to do functional and sport-specific movements as part of their training and return to sport if injured. There needs to be injury prevention mechanisms in place in their program. There also needs to be recovery techniques involved in their program. And of course, cross-training is an added benefit for maintenance and injury prevention as well. So how can Pilates help an athlete? So we spoke about the core as being the powerhouse of the body, right? Involving the abdominals, your pelvic floor, your hip, and your back muscles. So the principle of centering applies here, as that focuses all the movement through the center of the body to make it more efficient. And core strengthening for runners especially should focus on being body-centered and balanced. As you know, strong cores in sprinters are essential to get those high knees coming up and that arm swing going. So a strong core allows for good trunk and pelvic stability. It improves athletic performance and efficiency, reduces the risk of back pain, and it helps to transfer force from your lower to your upper body. So some Pilates-based core exercises. We have arm exercises. So we saw this earlier on the trap table, if you remember, with the ball between the knees. Here we are doing it on the reformer. So the springs are, they're usually 5 attachment for springs, and different colors on the springs denote different levels of resistance. So you can make an exercise more difficult, or you can make it more easier, depending on the number of springs and the color of the springs that you use. So here we're working on core engagement with extension of the legs and lifting the head and neck. So we don't do sit-ups in Pilates per se, but we do upper core contractions by lifting just the head and neck and slightly upper back off of the reformer. And then the weight is attached on, so pulling down the arms, there's resistance there. Your basic clam exercise as well utilizes your hip external rotators, especially for those who have very tight and weak hip external rotators, with emphasis on maintaining a nice, steady and level spine. All right. Other core exercises include a plank, but this is a dynamic plank. And I'll show you a video here of pressing out using the springs to get into that nice elongated position and then return. So the core muscles are essential to pull the hips in, as well as when you get out straight to maintain that spine in a nice, neutral and elongated position. And trust me, it's a lot harder than it looks. And we can also make this exercise more difficult by using less springs. So if the surface moves a lot freer, then it requires a lot more control of the body while doing the exercise. Postural awareness. Everybody's familiar with Janda's upper and lower cross syndrome picture. So tight upper extremity, upper trapezius and levator scapular muscles, tying with tight pectoral muscles, lead you to that nice rounded position of the shoulders and that thoracic spine. And that also leads to inhibited neck flexors and inhibited rhomboids and serratus anterior muscles, because those get stretched as the scapula is pulled apart. Similarly, in the lower body, tight erector spinae muscles, so that extreme anterior tilt of the pelvis leads to a tight iliopsoas and tight hip flexor muscles, and that stretches your abdominals, weakens them, and inhibits your gluteus, which are also very strong movers of your hip, right? So how can we fix that? Poor posture, as we see, can result in, as we know, can result in muscle imbalances, a weak core. It alters your movement patterns, making you less efficient. It increases your risk of injury, and it decreases your flexibility overall. So one of the things that we like to do is to first allow people to learn how to activate their core. And that can be done in several ways. This is just one of the methods, using a blood pressure cuff, just to see how the cuff is, the valve is moving and how much pressure is being placed on the cuff, and learning how to activate your transversus abdominis and multifidi muscles, as well as maintaining a nice neutral spine by contracting your abdominals. We can look at your neutral spine position in prone, so learning how to maintain a neutral spine, moving your limbs, upper and lower limbs, in a prone position. And if you notice, we like to focus on maintaining positions of your cervical spine, thoracic spine, and lumbar spine. And she's on a box. So this is another prop that's used in Pilates, depending on the activity that you want to do. So this is called a box. All right, posture correction exercises. So we spoke about those tight iliopsoas muscles. And for most of us sitting all day, persons who do a lot of sitting, who do a lot of bending, stooping, their hip flexors tend to be very tight. And that can inhibit athletic performance when you think about having to run, etc. So lengthening your hip flexors with stretch and your quadricep as well can help to improve your posture. Here we're working on strengthening your upper back muscles. So just turning onto the tummy, same straps that we used when we were doing the core activations. We're now using those arms to pull towards the hips, and that is recruiting all of the muscles of the upper back and your posterior neck, while maintaining that neck in a nice neutral position with your thoracic spine and lumbar spine. General strengthening, I mean, that goes without saying. Supplementing running or any other sporting activity with low impact strength work can be used as a means of cross training. It can be used to reduce injury, and it can also make you faster and stronger. And strength helps to improve speed. And the more power you can generate with each stride, the faster you can go. So if you're stronger and you can generate power for a longer period of time, you're able to run for longer and faster. Pilates is never meant to overload you. As I said, it's more of a gentler, low impact type exercise, but the force that you use, but it forces you to concentrate on movement and recruit the right muscles. So again, general strengthening exercises with the Pilates apparatus. We're looking at our hip abductors here, as well as maintaining posture with your shoulders in line with the hips, and using the ring here forces the chest to stay upright, shoulders are in line, they're not elevated towards the ears, and she's going to slide the reformer out and bring it in, maintaining posture while keeping the core activated and her hip flexors. Here we're looking at a bridge, and this is a single leg bridge, very important for hamstring and glute strength. With lifting, we have to engage the core. If you notice the alignment, our hip and knees are in line, so that hip is nicely lifted, and then this knee can be pressed out and pulled in for your eccentric hamstring exercises. Upper extremity strengthening. So again, stabilization of the area, so stabilization of that shoulder joint, working on those triceps, and also working on flexibility of the thoracic spine while doing the exercise. And again, we saw arms pulling down with the legs elevated, that helps with the core, as well as strengthening your shoulder extensors. Balance and coordination, proprioception, all key elements for any successful athletic performance. And these are essential for activities that require both upper and lower extremity movement. So the chair offers very little stability. So in this position, she's asked to engage her core, and she's going to press that pedal down while lifting the leg that's on top. And that's going to help to strengthen the hip, but that's also teaching her how to maintain her hips in line and not rotate them forward or back by engaging those core muscles and those glute muscles as well. This is a step up onto the chair. And again, this is the resistance, bending that top leg, pressing into the quad and raising up. So almost like a step up. So that's kind of a functional move here. So you're stepping up, and this is where the resistance is, but pressing into this knee will allow you to lift yourself up a little higher and lower yourself back down, all while balancing. Flexibility, another very important component of any successful athlete. So we can use the springs for stretch, and this is just working on mobilization through the hip joint. Very important for injury prevention and recovery. Lengthening maintains healthy muscles and reduces biomechanical stretch on joints. Dr. Jones mentioned that one of the most common things he sees are hamstring injuries, and that's usually due to lack of flexibility. And that's one of the things that Pilates addresses very well: flexibility and stretch through muscles and joints. This is a quadricep stretch as well as a femoral nerve stretch. So neural moves can be done as well as muscle stretch. Spine range of motion. So here, this is a dynamic stretch for your spine. So we're lengthening through those inner thigh muscles, and then we're working on thoracic rotation as well. And we know that normally the thoracic spine tends to be very stiff, and that can lead to increased pressures in the low back, right? So by mobilizing your thoracic spine, you can work on reducing the stress in the low back. And of course, opening the hips, internal and external rotation of the hips is very, very important for movement. Bridging, again, it can be used for range of motion for the lower back and the spine. So by the height at which you lift those hips, you can get range of motion going through the lumbar spine and the thoracic spine. And we usually require persons to bridge with articulation, which means that the movement is slower and muscles are recruited as you continue with the activity. So you start with the pelvis and the low back down on the reformer or the table. And as you slowly curl your pelvis in towards you, you use those hamstring and glute muscles to peel. We call it peel the spine off the reformer. So you're actually thinking of lifting a bone, one bone at a time up to your thoracic spine, usually the base of your shoulder blades. And then on the return, you're literally lowering yourself from one vertebrae down the thoracic spine to your lumbar spine, down to your pelvis, and then your buttock. So we can use bridging as a means of articulation and mobilization of the spine. Stretching your hip flexors, as we saw earlier with those postural exercises. And Pilates is interesting because you can make exercises more difficult or you can make them easier, as I mentioned before, depending on how heavy or how light the springs are. And we can challenge your balance by putting you in different positions. So on your back, on your tummy, we can go into kneeling, we can go into tall kneeling, 4-point kneeling, split stance. There are just so many different positions that you can work in while using the springs that it definitely challenges your balance, and it also challenges your endurance because you're now using and recruiting a lot of smaller muscles, and those muscles have to work for longer periods of time. So again, with balance, you're asking the patient to step up. They're on a moving surface, and they need to maintain proper posture, keeping that neck, shoulders, pelvis in line while lifting themselves up. Increasing the resistance. So by adding more springs, you can make it heavier for the arms. So it's more work to pull those arms down. By decreasing the resistance, so by using less springs, you make the carriage less stable. And so it requires more work to maintain that core, to maintain that head and neck while lifting extremities and moving the carriage. So this right knee would actually be sliding out and in while you're maintaining that alignment. And we spoke about endurance. Sequencing is one of those things that work on endurance. So for instance, if we wanted to work on an athlete who's an upper limb athlete and who has to do a lot of work with their shoulders, during the sequence, we start off with basic shoulder flexion and elbow flexion, shoulder extension into shoulder flexion. The shoulders are still moving, and we're adding in hip extension. And then staying up with the arms. So now holding those arms in place. So they're still working. We're now working on that hip extension and flexion. And then getting up, we're now adding shoulder horizontal abduction and adduction. So the sequencing of the events can determine what muscles you work and for how long you work them. And again, this is an example of how exercises can flow from one activity to the next. Plyometric work. So I did show you the jump board earlier. So for working on power, this is a good example. Depending on what you want to do, we can make it double leg, you can do single leg, you can do it on your side, you can do it on your back. And again, works your core, because once you're suspended in air, it's your core that has to maintain those legs and that head and neck while you move. Functional and sport-specific movement. So we're looking at, for instance, a golfer. And, you know, thoracic extension and rotation is super important for a golfer, as well as hip flexibility. So just using different activities on the mat, we can focus on rotation through the trunk. We can focus on using the club to help with shoulder mobility as well. And positioning them in this position works on hip internal and external rotation. On the reformer, we can get those knees pressing back, opening up the front of the hip. So this helps with hip extension. And again, thoracic and shoulder mobility. And even functional movements using the reformer, we can work on swing. We can look at how the hips move and balance as well. In terms of swimming, we can look at working on that streamline position. And then we can use parts of the tower to work on that pull, engaging those lats and posterior back muscles. For your runners, we can look at single leg balance here and just being able to maintain that position while moving the other limb. All right. And again, we're moving, but we're trying to remain stable. The core has to be engaged. Those shoulders are working that upper back and the trunk. And then we're going to add in some more functional movements here. We're also engaging those glutes as well, important for push off. And then we're going to you can slowly see how they can incorporate the arms as well to make it as functional as possible. So her knee is working, her toes and her ankles are working, as well as our hips are working to maintain stability in the pelvis. And this is just a quick example. Shout out to Sheldon, or one of our former Pilates instructors and physical therapists. And this is just an example of how a Pilates session can flow. He does it. The video is sped up, but we see here he's working on his legs, the ankle mobility and flexibility. Adding in those arms with the straps for working upper body, as well as core work, incorporating leg movements as well. Right. So all of that is core stability. Then we're working on mobility and flexibility through the hips. So circling through. Then shoulder stability here, as well as hips. Core work again, moving plank. Stable spine, engaging abdominals, neck, shoulders, spine in line. Notice the shoulders do not hike up to the ears, working on hip flexors. So sometimes when hip flexors are tight, they're also very weak. So important to strengthen the hip flexors as well as stretch them. Functional movements here, working on hip mobility and core, as well as stretch. And there's so many famous athletes that we know do Pilates as a means of cross-training and as a means of rehabilitation. So LeBron, Kobe, Ronaldo, all of these persons have spoken very highly about Pilates. A baseball pitcher, Jake Arrieta, he says, what I noticed from Pilates last year was that I have much better control of my body. I repeat my delivery consistently. My balance is much improved, and the mental and physical toughness Pilates requires to complete movements the correct way have directly helped me on the mound, pitching mound for baseball. And a hockey player, Philip Denot, says, I take it seriously. It helps me heal my mind. It's a great way to be strong and stay focused at the same time. I wish I knew Pilates before. I feel very good. And a quote from Joseph Pilates, I must be right. Never an aspirin, never injured a day in my life. The whole country, the whole world should be doing my exercises. They'd be happier. Thank you.
Thank you, Dr. Brissett. As you speak,
References are there.
as you speak, I am aware of my posture. I'm fixed myself. I can't even stay still. Very informative, very important information that you have shared. I've noticed that there are a few questions in the chat.
Okay.
But before I go to those questions, I have a question myself.
Sure.
And where do I sign up?
Oh, and I need to mention that all of this can be done at Body Forte. Thank them for allowing me to use the videos of stuff that happens in the studio. We're located at 9211 Barbican Road. And yeah, you can do individual Pilates sessions. We offer classes as well as physical therapy sessions. And I must mention, sorry, I should have mentioned it in the at the end of the presentation, that Pilates is not a means to replace anything. So it doesn't replace gym work. It doesn't replace performance work. It doesn't replace sessions, any specific sessions. We think of it more as a means to enhance performance. So it's used in conjunction with all the other training methods that persons use. As I said, it's more for maintenance, if no injuries. It can be used for injury prevention. It can be used for injury rehabilitation. And as a means of cross-training. So it's not meant to replace anything, but just to help to enhance whatever it is that the athlete is doing. Sorry, you were asking.
Excellent, excellent. When you get the chance, please put the information in the chat. I'm pretty sure there are others who are interested. I have a question from Anna K. Harvey.
Sure.
She said,
Can
Pilates...
She has 3 questions for Pilates. She's very excited, clearly.
Okay.
Yeah, she is. Can Pilates be used to reverse mild scoliosis? Less than 20 degrees curve in an adult.
It can be used, I don't know if I'd say reverse, but it can definitely help to strengthen the muscle imbalances that would occur because of a scoliosis. So just getting to lengthen the shortened muscles and to stretch and recruit the lengthened muscles, it can definitely help with that. It can help you to become more aware of where your pelvis is. It can help you to become more aware of your posture in general. But overall, it strengthens you in a way where you become less affected by the scoliosis. But I wouldn't necessarily say it can reverse it, but it can definitely help. If there are symptoms, especially, it can help to reduce some of those.
Okay, great. There's another question from Anna K. She asked, what's the difference between regular and reformer Pilates?
Okay, so Pilates is Pilates. What I mentioned in the presentation were just the different types of apparatus that can be used for Pilates. So you can do Pilates on the mat, you can do Pilates on the reformer, you can do Pilates on a trap table, which is that stable table using the springs. You can do Pilates on the Munda chair, sorry. So it's still Pilates. It's just being done on different apparatus, because a lot of the exercises can be modified based on the apparatus that you're on, and a lot of the exercises can actually be done on all the apparatus in different ways. So Pilates is Pilates, it's just the apparatus that is different.
Great. And one final question from her again. I will most definitely be, she says, dropping in for a couple of sessions.
Oh, sure. So I'm going to put the information in the chat shortly about where we are and our page on Instagram that you can check us out on, and also the telephone number to contact us if you want to call in and book a session.
So how does a person become a certified Pilates instructor?
So there are many different teaching methods. There are lots of different certification boards, I should say. So you really just need to check them out online. You have Pilates Method Alliance, you have Polestar, you have STOT. So there are many different schools that teach Pilates. STOT is more physical therapy based, a more rehabilitation type based Pilates. And then you have just persons who are interested in being a Pilates instructor where you don't have to have a lot of formal medical training. So it all depends on what you are interested in. But you can definitely look them up online. There are courses that are offered. Usually, most of them are abroad. We do have at Body Forte an instructor course. It's a basic instructor course for persons who are interested in learning about Pilates, which you can get more information on when you call. But to get properly and fully certified, most of the courses are held in America, and you can Google them. There's Polestar, there is Pilates Method Alliance, there is START, and a couple others bodies. Balance Body is another one. So you have a lot of different companies that offer Pilates certification.
Great. Thank you, Dr. Peart Brissett. Is there any further questions from the audience? I am seeing. Okay, Anna says thank you.
Okay.
Thank you
for your responses. All right. Thank you, Dr. Wendy Peart Brissett. Again, when I hear the word Pilates.
Oh, now you pronounce it right. Yes, Pilates.
I think about dancing and stretching, and it's so funny after you explain and explore and you go a little bit deeper in what it is. You know, I'm not all the way wrong, but I'm on the right track.
You're on the right path. But as I said, it's essential and it's useful for enhancing performance, because one of the principles, as I mentioned, is precision. And coaches will tell you that very tiny movements, very tiny tweaks can make a difference in an athlete's performance. And so when you're tuned into your body and tuned into very precise movements, that can actually help you when your coach is giving instructions on how to execute a skill or perform better going forward.
All right. Thank you. Thank you again.
Sure. No problem.
All right. So we will move on to our next presenter.
1 second. Let me just I just want to put again our payment information for those who are asking. So I'll say it again. The cost for, I should have put it there. Let me see if I can put it in. So it's $1,000 for the certificates for non-members, non-JSM members. So I'm putting the cost there as well as the payment information. All right. Please do remember to send the email to both those email addresses. There's jsmeducation@gmail.com, and please copy to jamaicasportsmed@gmail.com. Your proof of payment, that is. All right. Once you've done that, certification will be going over the next 2 weeks, and you can look over those. Thank you. Thank you, Mr. Middle.
Thank you, Dr. Brown. Yes, so we move on to Miss Shanika Morgan. Miss Shanika Morgan, she has completed her Bachelor of Science degree with honors in dietetics and nutrition at the University of Technology, Jamaica. She also holds a postgraduate diploma in education and training, as well as certified as an assessor with the VTDI. She has undertaken specialist nutrition courses in sports and wellness nutrition with the Institute of Nutrition and Wellness Studies, with the practice components under the guidance of the Jamaica Island Nutrition Network, and is currently the sports nutrition coordinator at JINN. She has worked with athletes and sporting clubs to improve their sports performances through proper nutrition intervention, as well as undertakes projects and lectures with various sporting groups, notably secondary school footballers, netballers, and the National Netball Association. A member of the Jamaica Association of Sports Medicine, she volunteers at events as a trained sports massage therapist, makes presentations and writes articles on sports nutrition. She has also involved in volunteering her nutrition service with the Heart Foundation of Jamaica. Miss Morgan was the Secretary, Treasurer, and Public Relations Officer at the Jamaica Association of Professionals in Nutrition and Dietetics, and has also served with the UTEC Alumni Association in a similar capacity for planning 5K road races. In her spare time, she enjoys nature, photographing, and adventurous activities. Miss Morgan believes that nutrition embodies the mind, body, and soul, which consists of a wholesome life with a balance of diet and exercise. Please welcome Miss Morgan.
Thank you so much for having me. And thank you for my introduction, Mr. Miller. Are you hearing me clearly?
Very clearly.
I'll waste no time and go ahead straight into it. Today, my presentation will be on sports nutrition intervention in sports medicine. And I'll be definitely going through the importance of sports nutrition in sports medicine. We'll be speaking about nutrient timing, pre and post exercise hydration and fueling, rehydration methods, and we'll be going through briefly a case study of a student footballer. All right, so why is, what's importance of sports nutrition in sports medicine? After, the previous presentations and what they would have entailed, nutrition is also a critical component in any physical or exercise regime that you're doing. So basically, nutrition and hydration are key for performance. They are basically what fuels your body to move, like putting petrol in a vehicle. Having the right amount of fuel is key. Having the right amount of fuel is basically, key to having your vehicle drive in a smooth and in an operative manner. So basically, you wouldn't put diesel in a petrol car. Staying hydrated basically reduces your risk of injury, muscle fatigue, which is basically key in your sports performance. Now, here are some nutrient timing guidelines. And this is basically general for every sporting activities. If you're a recreational athlete or elite athlete, this can definitely apply to the specific individual. And before I even go into this as well, just want to point out as well that nutrition is tailored for the individual person. It's not a one size fits all. So we want to ensure that we're bearing that into consideration at all times. So meal space, in order for us to have, proper nutrient, intake, is to ensure that, our meals are properly spaced and we are eating on a consistent and frequent basis. So at least 5 to 6 eating episodes for the day is very good for an athlete and even for regular persons as well in between meals. So 5 to 6 eating episodes is basically would look like having your breakfast when you get up in the morning. The first thing that you put to your mouth is breaking your fast. Then you will be having your mid-morning snack that you could have to top up and prepare yourself before having your lunch. That will help to avoid you being overeating after an extended time period. So usually we would, say to persons to space your meals at least 3 to 4 hours throughout the day. And that can even vary as well, depending on the individual. We can go down to even say 2 hours, depending on what we're trying to achieve. Then after lunch period, which will be having your heaviest meal for the day. And that's dependent on what activity that you will be pursuing at that point in time as well. That will determine the amount of food that you would be intaking. And in this case for athletes, and depending on how much energy or calorie intake that is needed, that will also vary as well. because not every athlete needs to have, let's say, a 5,000 calorie diet. Some it will vary even less than that, say for example, a 3,000 calorie. And that will be taken into consideration by the sports nutritionist to do that sort of evaluation and calculation for that specific athlete. After lunch, you will be having mid-afternoon snack. Then you can finish off with dinner and or bedtime snack, depending on your time period for heading to bed. So in addition to that, meals, as I said before, span between different time period apart. And we have to take in consideration our overnight fasting, which will also vary for the individual, because some persons will go, for rest at a later time period, which will also minimize or extend their fasting, depending on what time their last meal would have been. So, as I previously mentioned, that nutrition is based on the individual. So each athlete will have different dietary requirements, and these are very much dependent on the sports that's played, the age of the athlete, their body size, the training that is taking place before either the competition or during for the preparation of the sport. Environment as well is to be considered for training and competition, as different environments. The environment varies if it is very cold and if it is very hot as well. That will depending on the amount of sweat or fluid that would be lost and other things that would be taken into consideration for the athlete to vary, in addition to their sex as well. Male and females are different, so obviously their calorie intake and their training regime will also vary accordingly. So nutrition one-on-one is basically, as we had mentioned previously, what you eat, when to eat, and how much you're eating. So basically, these will help with the delay of the onset of fatigue, enhances your mental alertness, enhances recovery, and it prevents and slows down muscle wasting. So it's very important that we are getting in the quality of food in our diet at all times throughout the day, and to ensure that the athlete is being informed of how much fluid that they should be drinking before, during, and after training or competitions, and the amount and type and quality of food that they should be having. There are 4 R's of recovery nutrition, and they include rehydration, refueling, repair, and rest. Now we're going to go straight into hydration strategies. And basically during exercise, we all know that we lose fluid, and that also varies depending on the individual as well. And also electrolytes will be lost through your sweat. So the key electrolyte is sodium. So if you don't replace sodium, both in fluid and sodium during exercise, you can become dehydrated. So the single largest contributor to fatigue during exercise is dehydration, which is caused by fluid and sodium losses. So there will be inadequate fluid and sodium, that will make your heart work harder and make exercise much more difficult for the athlete. So it's important that we inform the athletes that, and let them know and even follow up with them, even if their coaches could definitely do that to ensure that they are properly hydrated before, preparing for the competition and even during training, because this will definitely impede their performance and their outcome. Dehydration also improves your concentration and the ability to make tactical decision, and a very small, minute amount of, for example, 2% of fluid that is lost from sweating will definitely impair your performance and leads to serious amount of dehydration that could lead to about 2 to 3 pounds, for example, of your water weight that's lost. So it's important that the athlete can weigh before and after their exercise or training session to know that, to actually know how much fluid that they're losing to replace the amount that is lost, and to ensure that they're properly replenished. So it's important for them to rehydrate with water up to an hour, and even after an hour, and to include sodium, potassium, and magnesium beverage, because, fluid will be easily absorbed in the body. And basically to avoid over-consuming fluid to prevent weight gain. Stick to a hydration plan with your sports nutrition specialist, and this is very much important. We've been to a lot of events, and we've seen firsthand, what dehydration or the lack of consuming adequate amount of fluid can definitely do to the athlete. And it can't be overstressed enough for how much it needs to be taken home to, especially the younger athletes who are in school, to ensure that either their coaches, they are proper persons who are in place to ensure that they are properly hydrated and not to harm themselves without not having the proper information to guide them. So prior to any training or exercise, we can have, your carbohydrate with protein and water during your exercise, to include some carb and water. And this also depending on how long the exercise or training session will be. And afterwards, you will have, a carb, protein, water, and electrolytes to basically replenish all that you have lost, and to ensure that you are adequately resupplied and rehydrated after your sessions. If you'd like fast recovery, it's very much important that we can add some vitamin C and possibly glutamine, depending. And at least you can have at least 1 to 2 cups up to 30 minutes before you start either exercising or a competition. And during your play, at least 4 to 8 ounces for every 15 minutes of your training session or competition. So carbohydrate is the primary source of fuel. It's the main fuel that, our brain and our muscles operate from. And this is very much important for, even the athletes to know, because you have some athletes will minimize the amount of carbs that they need, and it will definitely impair them as well. So it's important that they are having the correct amount of carbs in their diet, and to basically ensure that it is tailored to their sport, the individual, and their sex. So starting exercise with a full carbohydrate stores can delay the onset of fatigue, and it helps to train and for you to compete more effectively. So your performance can suffer if your diet does not provide, sufficient amount of carbohydrate. For pre-exercise meal, it's important, that we have or we space our meals, as I mentioned before, accordingly, to know that we are proper, nourished before starting any physical activity. This basically helps to promote glycogen synthesis and storage. It minimizes your fatigue during exercise, because there are a lot of times where you will see persons who are going to exercise and they have some sort, either they'll be shaking, their hands or feet will be shaking, and when you do ask, what time was the last time you've had something to eat? They say it's either a few hours way before or in the morning, and no, it's afternoon, they have not had anything to eat or drink. So try to be on top of, the athlete in terms of to ensure that they are following through. And there may be different circumstances why as well that they don't eat. There are different reasons for persons who, for example, may not have, economical, circumstances that may impede an athlete, for example, for them not to have regular amounts of meals. So we can also try to find that out as well. And glucose is used during, the exercise, during the exercise aspect, depending on the length and the time period for the training or the competition as well, that could basically use as a quick top up. High carb, it's important for us to include high carbohydrates, have moderate amount of protein, and for our diet to be low in fat for the athlete, depending as well. So during your exercise, the important to having our meals or to have a top up during our exercise is to prevent hypoglycemia. It helps to delay fatigue. It spares the muscle glycogen, and basically to include around 40 to 65 grams of carbs per hour for your exercise, or around 0.05 to 1 grams per pound for every 20 to 30 minutes. In addition to that, the 68% of carbs can be included in your solution. For example, you may have any sort of beverage, ensure that it's around 68% of your carbohydrates included. For post-exercise, it helps to refuel for the next exercise session. It replenishes your muscle glycogen stores. And at this point in time for post-exercise, you should be having at least 1.5 grams of carbohydrate per kilogram immediately after physical activity. And the first 30 minutes is quite optimal. And that's where a lot of absorption will be taking place during that immediate 30 minutes after your physical activity. So it's important for them to make use of this time period to ensure that they are properly fueled and replenished at this time, and to include at least 0.2 to 0.04 grams of protein per kilogram of the person. So other nutritional considerations are the branch chain amino acids, the leucine, your valine, or your isoleucine, which are very important as it offsets muscle damage and soreness. Calcium, magnesium, your vitamins and phosphates, antioxidants, it helps for your, these are basically bone mineral supplementations that are critical, as you have some there'll be certain athletes who are very much limited in, for example, calcium, and with the limitation of that, as well can affect their bone density and may end up having a lot of injuries or fractures. Omega-3 fats, it offsets the inflammation and soreness and associated symptoms such as joint pain and morning sickness, just to name a few. So I'll be going into a brief case study. to provide you with some insight of what a student athlete, how their regime is, and how we can go forward from it, what was done. So Jim, who is a 19-year-old college student, is the captain of his football team. And he is definitely interested to be drafted to play in a competition. So he, second, let me get the information. So his anthropometric assessment was done, and his weight was 89 kilograms, which is 196 pounds. And at the end of which was at the end of his previous football season, sorry. He was 6 feet 3 inches tall. And in preparation for the new season, he did 1.5 hours per day weight training, which was 5 times per week. He did also an additional 1.6 hours of running, which was about 6 times per week, and also an hour playing a game of basketball most days of the week. So the reason for his consultancy at the time was within the first month of training, he lost 3 kilograms of his weight despite eating lots and lots, which he reported. He was fatigued and starving at the end of workouts and was frustrated with his weight loss. He felt that, the lack of recovery between training sessions was preventing him from making the desired weight and his performance gains. His existing dietary patterns was that he ate high calorie food in the afternoon and also in the evening. In the mornings, at around 10:30, he will have a Gatorade and a sports bar before his weight training, and typically goes without breakfast during the week. Usually he eats out, which is either a sub sandwich, and he avoids soda, but he drinks lemonade with his meals and water before and after his practice. Sometimes he would have a sports bar between afternoon practice, and which is his main energy intake, would be at dinner time. And on his way home, he would have a medium-sized pizza, which includes sausage, and he would also have a lemonade. Before bed, his protein, he would have a protein shake, which consists of 1% milk. Now, this is his food intake. As seen near his morning snack included a sports bar and a Gatorade, the sub sandwich with the lemonade, and for his afternoon snack, he will have a sports bar and dinner, which would be the medium-sized pizza, and he will end with the evening snack of 1% milk and a scoop of protein powder. So after we got this information from him, his nutritional assessment, that his self-reported daily eating intake was 3,500 kilocalories and 498 grams of carbohydrate, which is 5.8 grams per kilogram of his body mass, 145 grams of protein, and 106 grams of fat. He reported a low energy intake of 1,000 kilocalories, and his daily menu we found that was low in fiber, which was 18 grams versus the recommended 20 to 30 grams. There were no recording of his fruits and vegetable intake. The adequate estimated intake of protein was also noted. Intake of calcium was 2,500 milligrams per day, which is the upper recommended intake. He had a very, very high sodium intake of 6,000 milligrams per day. His carbohydrate lower end of his recommended intake. So his carb intake was at the lower end as what he would have needed as an athlete, and his incorrect nutrient timing as well, and his refueling after training sessions was incorrect. So the goal in terms of nutrition or intervention to help him at this point in time was to increase his daily energy and carbohydrate intake and improve his nutrient timing and hydration. Moderate, we also wanted him to include, reduce his sodium intake, to have moderate sodium intake to obtain the recommended fruit and vegetable intake, as well as none was previously recorded. His intervention to improve his diet at this point in time was to include breakfast, as he does not usually have breakfast on a frequent basis. And for example, he could have included a bread or bagel, peanut butter, and banana before his morning weight training. He could eat a high carbohydrate snack with a high glycemic index, providing at least 1 to 5 grams of carbohydrate per kilogram within 30 minutes after all his training sessions. And that could include a fruit, a sports bar, or a sports beverage. Replace his high fat dinner choices with a meal that is higher in carbohydrates, has adequate protein, and that is also low in fat. For example, we could replace the whole sausage pizza with half a medium, either thin crust vegetarian pizza with plain breadsticks or a garden salad or an orange juice. He could also increase his, it was recommended for him to also increase his vegetable intake to include fiber in his diet. And that was also the reason to include the fruits as well, because his fiber intake was also lacking. Was also encouraged to have consistent fluid intake throughout the day and during his training sessions, and to switch to a 2% milk in protein shake to increase his energy content. He should, so after all of this was intervention was done, the outcome was that he started to eat a high carbohydrate snack immediately after his workout, and he found that his body recovered more completely from his intense trainings. So even though he was hesitant to eat breakfast, he did so on the days that he did weight training in the morning, and noticed an increase in energy during his sessions. And in addition to that, he noticed a 2-kilogram gain in his muscle. So in addition, his fruit and his vegetable consumption increased. and his carbohydrate and fiber intake both reached the recommended levels, which was 622 grams of carbohydrate and 37 grams of fiber, and cutting out the sodium, high sodium meals that he was having, and to reduce his serving size of the pizza that he having as well. So basically the coach noticed these improvements and recommended him to play in the game upgrafting competition that he was scheduled for. Now, summarizing everything is very important, that as we had mentioned, that proper hydration for optimal is needed for optimal performance before, during, and after training, and the quality and the quantity of meals in preparation and recovery after exercise are also critical as well for any athlete, in addition to that. Thank you so much for hearing my presentation, and that is the end. Do you have any questions?
Thank you. Thank you, Ms. Morgan, the nutritionist, for that presentation. I'm pretty sure that it has value to many of the listeners. I sure have learned something. A few things have been reiterated as well. To the audience, if there is any question, you could raise your hand or post it in the chat. We have a question here from Lisa. Lisa says, what time did you suggest that the case study Jim have his breakfast?
Well, that would, for Jim specifically, let me just say that for, in general, for all athletes, their timing would be different for breaking their fast, which is breakfast. So in this case, for Jim, his breakfast time period would have been around 8 o'clock in the morning. And it can also be earlier depending on the time period that he would have woken up, because we did not go directly into those other specifics when he woke up and, the time period that he would have ended up having something before his training session.
Okay. Ms. Morgan, question. What are some of the common mistakes that you find with athletes when it comes to nutrition, in your experience?
Well, as I noted out earlier in the presentation, that one of the biggest things that we see quite often is lack of hydration and the incorrect nutrient or feeding times, nutrient timing. A lot of persons, they underestimate the importance of having quality meals in their diet, and as so just look as food and just to eat. But it's very important as well that we all pay attention to the quality of our meals to ensure that it has the nutrients that are needed for our daily activity and optimal performance, especially for the athlete. And that's where that definitely comes in. So those major two things are utmost of critical things that are noticed.
Okay, great. Anyone have any question? I see Shara, your mic is open. You want to ask a question? I guess not. Miss Morgan, what are some of the foods that you find athletes consume that would reduce their minerals in their body?
Well, basically a lot. I've experienced, athletes, both junior athletes, that they have, for example, we call it quote unquote junk food. Mm-hmm. So, for example, I was within a school, a high school, and these athletes were consuming bag juice, banana chips, well, nothing is necessarily wrong with banana chips because it's carb, but how, remember, we're talking about the frequency as well, and how is it, sustainable as well, for the athlete, depending on their activity level. So they will basically feed on this, have candy, and, go for a while even without hydrating themselves. And, because some of them are, for example, the females would be watching their figure. So they don't want to overeat, as they would say, to gain weight and do certain sort of weight training in that aspect as well.
Okay. A follow-up question to that. Do you find after consultation that they adhere, or is it difficult for them to adhere what is put forward to them?
Well, as I'd even mentioned briefly on the economical, conditions as well for certain persons, for some persons. So when you consider that in as a factor, it's going to be challenging, definitely. And nutrition and about better eating also comes back down to your mentality, your mind, how you are well received of the information, if you consider it very much critical for you and your health going forward. Because even though we may have, get the proper information but not put it into place, it also comes back down to your one, either economic status one, and it could also comes back to your mentality. What is it that you believe? Do you think it's important or not? So definitely answer your questions. It can be both sometimes, but it's a constant. It would be constant following up and responsibility on the athlete part.
Okay, great. I have another question here from Anna K. She asked have you ever worked with any plant-based athletes?
Personally, plant-based, no. No, not strictly plant-based athletes, no.
Okay. I have another question from Lisa. Do you opt for food first approach, or do you suggest supplements such as protein powders?
Well, nutrition is definitely, straight food, quality food first. That's very much critical in all aspects because we are getting our nutrients from our different foods that our 6 Caribbean food groups suggest or have. So it's important that we are getting a variety of foods and in different colors, as everything has their different benefits as well. So food first approach is critical.
Right.
If they would need supplements, that will definitely come back down to if there's anything that they lack, or if they need certain, based on certain sort of recommendation from another medical support that could be factored in or so. So it varies.
All right. So food first, supplements second. There's a deficiency, then we'll use supplementation, but always food first. That's what you're saying.
Correct.
All right. Thank you, Ms. Morgan, for your presentation. It was enlightening to me again. Thank you very much. We'll hand over to Dr. Diallo Brown.
Sure. Mr. Miller, just to make the point as well, Ms. Morgan, I liked what you said where, as you're answering the questions, that for many of us, food is just food. And then I'm thinking about the quality of the food, or the quality of the fuel, as you mentioned. So I think that is something that we need to get across to our athletes. Maybe sometimes our athletes' parents. If I guess I could go into a question. What do you think, for example, now of maybe feeding athletes, very high carbohydrate foods, maybe for recovery and so on the basis that they're young, maybe they're young athletes, let's say young track and field athletes, young swimmers and so on. They're young, so they probably burn it up. Is there a concern as to if they're feeding them a lot of, maybe it could be pizza or, those kinds of foods. I don't want to say junk food, but those kinds of foods. Is it a concern for young athletes, of course, being young and growing, of course, they're very active and so on. Is it a concern for them, or what's your thought?
I must start off by saying that, you know, for an athlete, they actually have a upper hand. And I
Right,
won't say all of them, some depending on, as I said, their energy level, the type of sport that is required for
right,
them to, you know, implement or do a lot of training. And that will involve, you know, their strengthening strategies, etc.
right,
So for some persons, it may be beneficial. Let us use, for example, like maybe a Bolt. Is maybe calorie intake when he was, you know, performing could either round up to over 6 or 10,000 calories. And in certain cases, you know, sometimes you need to condense that. And for example, we're going to use a pizza, as you had mentioned. You have certain foods that have high amount of calories, and how you're going to get that is, you know, from having certain type of food. So it's not like it is bad. Food is not bad, and that is something, another thing that we need to change from
right.
person's mind and mentality. It's the abuse of food, and as I'd mentioned, the quality and the quantity that is having. But as I said, in terms of the athlete and elite athlete, I don't think it should be much of a problem, because those are some of the stuff that they have to definitely intake to get their calorie intake one. But you have to look on, as I said, the amount of fat. So if you're having excessive amount of fat, depending on if it's before, during, or after, you know, that is where the sports nutrition is coming to play, to gear that and to gear it towards what is needed.
Right. Okay.
I'm not sure if I answered your question.
I think it did partially. I guess as you said, it's not
For
foods
the,
necessarily bad.
oh, you mentioned about the child. For the child,
Right,
for the child, no, you, as I said, it comes back down to their energy, you know, that is expelled, what is based on their exercise or training need. So it's not like they can't have, you know, pizza or certain type of food maybe that you're thinking about, but everything comes back down to a balance. How much, how often that they're having this, depending as well during their, if they're preparing for competition wise, you know, if it is necessary, and how much fat would be included in that as well.
Okay. And you're not concerned about the so in other words, yes, the calories, they can manage the calories, but what about the nature of the food itself? In terms of, could it impede their performance in some way? Could it slow them down, make them bloated, or is that a concern? Especially for the young athletes, or maybe it's less so for them, or athletes in general, maybe it's less so for them.
You're asking the type of food, if it will affect.
Yes, right. If the types of food could that could be a concern for athletes, whereas regular folks, then we can't get away as much, as you said. We can't get away as much with some of the excess calories, but not just calories, but just the nature of the food. Maybe it's really very high in oil, for example, very high in fat. I figure that kind of food might slow you down, so to speak. But is that maybe less a concern in athletes, for example?
As I said, depending on the type of athlete, one,
Right,
and
okay.
also the individual, because somebody could have a particular type of food and they don't have any bloating issues, as opposed to another person could have the same food and it could be affecting them because of different reasons, maybe allergy, or, you know, certain allergic reactions, or things that they are not, that impedes them. So there are different reasons for that to happen, but that all comes back down specifically to the individual. As I started out to say, that nutrition is based on the individual. It's tailored for each individual, regardless.
Right. Okay. Thank you for that.
You're welcome.
All right. You mind taking on your share screen? I think we can. Is that about it? Any further questions?
Sure.
Is anybody seeing any questions? Any more questions there?
No, no more questions.
All right. Well, I guess that means we've come to the close of another Keeping Pace seminar. So let me just say thanks. Thanks, of course, first of all, to our presenters. Well, first of all, to our attendees. So thank you for attending this Keeping Pace. I think we had up to 80 something.
87.
87. Oh, well, there you go. So thank you all for making this another successful space. Thank you for your engagement. Thank you for your questions and for your interest and all that. We do thank you for that. We thank our sponsor, Medimpex Jamaica Limited. We thank you for coming in and sharing your ProTech line of orthopedic, I guess orthopedic and sports medicine support equipment. We appreciate you sharing that information. And of course, we do thank our presenters. We thank Dr. Jones, who came in pretty short notice. I wouldn't say that's substitute, but he came in at short notice. But he came in and did very well presentation and really updating us on surgical and non-surgical orthopedic interventions for different sporting injuries. So really appreciate that. So Wendy Pierre said, she aligned us on Pilates, a lot more on Pilates as what Pilates really is and how we can apply it to both the athlete and the non-athlete for rehabilitation and I guess general exercise as well. So thank you, Dr. Wendy Pierre said. Thank you, Ms. Shannon Morgan as well for really highlighting the crucial role of nutrition, sports nutrition. I think when we have conversations, I don't think we pay enough attention to that in our local sporting context. So hopefully something like this helps to kind of get the word out and have persons paying more attention to that. So we do thank you very much for that. All right. Then of course, I'd like to really thank the Education Committee, broadly speaking. So this is our last webinar for both for this year and also for the current administration. So things will be changing come November. I do thank the Education Committee over the last 2 years for keeping keeping pace going and keeping us in pace. I do thank each member. Each branch has its own education committee. So I want to thank the branches. Thank Western Branch Education Committee, Mr. Marlon Thomas, and I think Ms. Audrey McIntosh has contributed there. So thank you guys and your team. We thank the Central Branch, Mrs. Karen Brown, Dr. Jordan Simpson, and Ashley Stevens, right. I thank all of you guys and your education committee team as well. And then of course, I thank our main branch, Mr. Miller, thank you as co-chair. I don't know to big up Dr. Joan Ratchy, always our support person, keeping us in line, and on time and those kind of things. So we do thank Dr. Joan Ratchy. Christine Edwards, I don't know if she's still here, but I thank her for her contribution as well. And of course, we thank all the presenters that we've had. We've had Keeping Pace continuing throughout the pandemic and has been on the Zoom platform. We thank all the presenters for previous Keeping Pace, which I'm sure some of them have been as well. And of course, we thank our members, our JASM members for keeping the Keeping Pace seminars interesting. And of course, our non-members who still attend. Some of them pay for a certificate, some of them don't, but they attend and they get information and they ask questions. So we thank all of you guys for keeping this going. So I think that is just about it. Thank you all for attending, getting lots of good comments here. Seeing all the comments, lots of positive feedback there. So thank you all. I'm going to go again and put the payment information, both the instructions and the cost as to how to pay for a certificate for those who wish to do so. All right, thank you all and enjoy the rest of your Sunday afternoon into evening. And thank you very much once again.
Thank you.
Most welcome. Most welcome, Ms. Mac. All right. Most welcome, all the comments. Thank you very much. Yes, Ms. Mingo, thank you. Thank you. All right, so I'll keep the chat open for a while, keep the meeting open for a while. We will close. Thank you all.
Sent you a note, Diallo. I sent you a note.
You did? Okay. All right, thank you.
Well done.
Oh, it's a good note. Okay. Thank you
Yes,
very much.
it's a good note. All right, bye.
Bye. All right, I'll close the meeting in about 2 minutes.